This is not a podcast on what causes cancer. This is not a podcast meant to scare you. This is definitely not a substitute for any medical advice. This is a navigation conversation to help you, give you that clarity when cancer really enters your family or your neighborhood. You are not starting from zero, so that you are resourceful. So that is the intention of this podcast. Today I'm conversing with Dr. Abhishek Krishna. He is a radiation oncologist and assistant professor at Kasturba Medical College, Mangalore. When I looked at his profile, I found, apart from his specialization, he cares a lot about one particular topic, which is economics of cancer treatment. And that makes him a perfect guest for today's conversation. Thank you so much for your time.
Thank you, Clinton.
Yeah, before we even talk about treatment, cost, diagnosis, I think we have to go to a moment where everything starts.
Correct.
In all of your years, what's the one thing that cancer patients wish they had known a year earlier?
I think wasting initial time, even though they had some symptoms, they probably ignored it, or they probably didn't have much idea. Ignorance, I wouldn't say much, because probably they won't have an idea. So they might have gone or not gone to the doctors or something. So I think one thing that I probably would tell is coming to the doctors late. That is a common thing. I mean, it is even I think general public also may know it. But that is one thing that even I have seen, that patients wish that, they had probably come to us 1 year before or 6 months before, or having not neglected the symptoms.
What usually delays cancer diagnosis?
Correct.
Is it lack of symptom, fear, or misunderstanding?
Yeah, I would say a mix of all. So for anything, for any symptom to develop, there must be something grossly going wrong. Especially in cancer, basically we have 4 stages: stage 1, 2, 3, and 4. Stage 1, most of the times the patient won't have much symptoms. For example, let us take oral cavity or a mouth cancer. The maximum symptom he may have is something like a small irritation in the mouth, or some, when he's taking some spicy food, oily food, some irritation. So that what happens is most of the other symptoms are also, like if he's having a normal ulcer also, it is the same symptom. So cancer is something like there'll be unique symptoms to it. It is going to have the normal symptoms which other diseases also have. Basically, we have to, sort of tell the patient or ask the patient that the complete flow of, whatever he had, that we generally do when we take the history. But generally, one is that symptoms are same like other diseases. They probably do not know that, or wouldn't have suspected that, okay, it might be because of cancer. One is that. Second is definitely there is a taboo. How much ever we may talk, there is definitely a taboo in the society that if I get diagnosed with cancer, what others will think, or in my society, what will people think? That is a known fact.
Okay.
It is definitely improved, I would say, what I'm seeing from the past 10-15 years, but that is there. Third is, many people have this sort of mentality that, okay, if I go for test and if I get diagnosed with cancer, I'll have to, go further test, and I have to spend more and see this. I will just take some medicine and see. If it doesn't reduces, then I will go further. That is again one more reason. Fourth is fear, that people have the fear, if I get diagnosed, so they keep it inside, they won't tell anyone. So we have had a lot of cases where, with patients with, say, breast cancer, they would have felt a sort of a lump or a swelling in the breast around 1 year back, 6 months back, but they have not told anyone. One is because they don't want to put burden on someone, or they are scared. Basically, they are scared that, if I tell them, they will take me to the hospital, do all the tests. So that is probably a thing that is hindering the early patients coming. So these 4 to 5 points are generally the psychology, what you asked.
I mean, everybody is vulnerable for that. Like even Steve Jobs, when he had pancreatic cancer.
Definitely.
Yeah.
So main thing, like I said, is the early diagnosis. It is important. But the paradox, the stage 1 cancers usually do not have, that many symptoms. Like I can give you 4 or 5 examples. So if lung cancer, maximum he may have is a cough in the early stages. Second is oral cavity, like I said, he may have some ulcers. Breast, you may feel some small lump. So stage 1 breast cancer, when we tell, the lump is generally said to be less than 2 centimeters. So sometimes you won't, when you're taking bath or when you're, touching your breasts or anything, you won't even feel it sometimes. If the patient is having, say, GI or gastrointestinal rectum or a large bowel or large colon, what we call. He may have some amount of once in a while, bleeding, some amount of weight loss. So stage 1 cancers do not have that many symptoms. That is why one of the reason why probably we are not able to see
Right.
that many patients coming to us.
So you
with
would
stage
see
1.
people coming from stage 2, is it?
Yes, most of the things in India, many would agree with me that we see mainly in stage 3 and stage 4. But one positive part is that from the past 20 to 30 years, we have been also seeing sort of stage 2 and stage 3, that mix. But majority is still stage 3rd cancer or a 4th stage cancer. Stage 1 we see, but not to that extent as we see stage 3 and 4.
More awareness is needed
Yes.
so that people come at
Come
stage,
stage
1.
1 also.
So rather than looking at the symptoms,
Yes.
is there a pattern of changes that would signal that you might have high probability of cancer?
Yeah. So one main thing that is that the symptoms, whatever you're having, it doesn't go off on its own or stays for a long time. For example, I or you may have cough tomorrow. If I get fever, some small, I may have a cough. But if I take some medication, some syrups, or if it is severe, I take an antibiotic. Max to max 1 week, 2 weeks, it will go off. Same with any mouth ulcers. If I take some vitamin tablets, or if I change my diet for a few days, it will go off. Some amount of weight loss can be there during normal infections also. Once patients start eating, it will get normal. But in cancer, generally that doesn't happen. What happens is the symptoms go on increasing, or symptoms doesn't go away. So there are two things. Symptoms may increase immediately. Today I am having, say, this particular symptom. After 5 days, that same symptom has doubled. It has become 3 times. Or other way also, that we are having patient is having a symptom, but it is not going down despite multiple medications. He has gone to multiple doctors. He has met this. All the tests are done, but that symptom is still persisting. So that is one major thing, and that is probably the only thing or major thing I would tell.
It's not about intensity of pain.
No.
It's the persistence
Yes,
of the
persistence
system.
of pain. It is persisting for months together. I would give a timeline, maybe months. Days generally, if it is within days, generally very, very unlikely that it is related to cancer.
Overthinking.
Yeah, it could be more of overthinking. But when it's months to years, most likely months. Having said that, sometimes, most of the times, whenever we do additional tests, it turns out to be negative for cancer. It could be some other disease also. But at what point probably they should, kind of think if anyone in their family is having probably these symptoms, if their symptoms are not going down, if they're having the same symptom from few months, then probably it is good, to take them, get evaluated, and clear their mind of that they are not having any symptoms related to cancer. But having said that, we should not, over panic also, because thinking
Right.
that I have some pain from this one, because every symptom need not be cancer. So that is also there. Like I said, when we talk about these things that, but in a general, because we cannot pinpoint, we cannot make guidelines for each and everything.
Right.
What we generally tell is, if you're having the symptom from months, better to get it evaluated. Don't worry if it is not cancer. Very good. Even if you have diagnosed with cancer, it is good that probably it might be in an early stage, so we can definitely treat it in a better way, both with better outcomes and better this one.
So when they get subtle symptoms,
Yes.
so who the best person to approach? Is it a general physician or directly an oncology specialist or
No one directly walks into an oncology department saying, I have this particular thing, treat me anta. Generally, they go to the general physician, or first, most of the times what we see, they go to their family doctor. The family doctor is the right person initially to go with if you're having symptoms. He will examine generally the patient and see what is the problem. If he suspects anything, then he will refer to a specialist. For example, I can give an example. If some of our patients whom I have seen in the last few years, they initially went to the general physician with the throat pain. So then he examined and everything, and then he suspected that, okay, something could be, wrong. So he referred them to an ENT specialist. ENT is ear, nose and throat specialist. So ENT doctor did an examination and found out that in the throat he's having a small, lesion, from which the initial tests were done. And once everything was done, they referred to an oncologist. So generally in our clinic or in wherever in the world, directly coming to oncology is rare. Generally, they would have had an initial, doctor in between who had generally examined them. Generally, they go to their general physician, their family doctor, or a general specialist like an ENT specialist, or a lung specialist, or a breast surgeon, general physicians. These are the generally doctors whom they directly initially go with their first symptom. They will duly examine, do all the tests, and then come to a conclusion that okay, this could be cancer. Then they take the help of a oncologist and then refer, and then it takes over. That is a general pathway that we generally see.
So, do you think people overestimate cancer or underestimate cancer?
I think as of now, underestimate, because what reporting, what generally data we have, that is only of the reported cases. So generally, for example, in India, according to 2024 data, because this year's data will come only by next year, we see around 15 lakh cases reported. 15 lakh every year, new cases in India. 14 to 15 lakhs in a year.
Out of 100 CR population.
Yeah, these are what I tell, the reported cases. So either they have, come to a setup where these are being reported, for example, to a hospital, to a oncology center, wherein what happens is we get the data and we report it. In other places, there would be so many cases which probably they have not even reached the hospital. They have not even reached the setup where they are reported.
But in terms of patient psychology,
yes.
So how do they perceive cancer? Do they underestimate the cancer's thing or overestimate? Do they have over fear of the cancer?
So in patient psychology wise, they have definitely over fear. Very whatever we tell that we need to have a positive outlook and everything. Generally, what we see is that the fear of cancer is very, very high, and they over express their fear. Definitely, when we tell someone what we call breaking the bad news, that is what the medical term is. When we tell someone that you have been diagnosed of cancer, it is natural for them to feel, upset or feel this one. But there is something called coping. That is, after a few days or a few weeks, they sort of get understand it that okay, they have, but they have to take the right treatment. They have to do this. But still, a large amount of patients do have the fear of cancer, saying that if I have been diagnosed with cancer, it is the end. And most of the family members also fear. That is why we deal with a lot of family members who tell not to tell the patient that they have cancer. So it is sometimes difficult.
Is it a right move?
So generally in medical thing, it is not a right move, because the patient has all the right to know what is correct with him. Especially we see this in young population or extremely old population. We have had both extremes. One gentleman who was say around 85 years old, he had been diagnosed of stage 4 cancer. His their son family came to us after the diagnosis. They hadn't told the patient. So when we were talking, he requested us that don't tell him. Anyway, he is 85 years of age. We know that it is stage 4. He doesn't have too much time. Till whatever time he is there, let him be happy. Let him not, have the guilt, because he has been like this from before. If he knows that, he is having some major illness, he will get completely upset. So in that situation, we are also sometimes in a fix that.
I think even I would have done this.
Yeah, that's it. So is it right? Is it wrong? Is it right? Probably no. If we talk of the
but
doctor.
Depends on the stage of the cancer, no?
Correct.
So what would be people's reaction? Stage 4 would be extremely difficult. Stage 1 is moderately. So how do you break out the news for each stages, and how patient would react to the each respective stages?
Correct. So generally, first I ask them what they know about it, because we are not ideally supposed to break, directly to the patient. It is not only for cancer, for any major illness. Suppose if anyone is diagnosed with, chronic kidney disease, or some major illness like heart attack, or any brain damage. So in case of accidents. So generally, what I personally do is I ask them what they know till now. So that at least sets some context, that they won't tell us that no, we went to this particular doctor, our general physician. he told that there is some problem in the patient. Then I know that, okay, they know something. Some patients may already know the diagnosis. We went to this, we have got the reports now. They told that it is cancer. So then they have referred it to you. So then I am much more, comfortable directly telling them that this is the things. But if a new person comes, it is very important initially to know what they know about it, and then slowly break it. Tell that this is the thing. We did all these tests, and this we had some initially queries that it could be something else. It could be infection. It could be cancer. It could be something else. So we have run all the tests, and now we have at this one. Then we discuss it to the patient. If it definitely, like you said, there are some difficult situations. One is stage 4. Stage 4 means it has spread to other areas. So it is very, very difficult to treat it. So to convey that is very, very, very difficult. I completely agree. If it is a stage 1, at least we tell them that, it is a very good thing. It is in stage 1. We can completely cure it. 2 and 3 is in between, like I said. We tell them these are the things. Apart from stage 4, 2-3 other scenarios that we find it very difficult is young patients. I'm not talking about children. I'm coming to the third point. But these young adults, what we call, they are in the range of, I would say, 25 to 35 or 38 range. They are the working people of the family.
Right.
So that is a very, very
Sensitive
sensitive spot because, they are the only, most of the time they are the only working member. And generally their mother or their father comes. And then they are very, very emotional. That we have seen that is a major group. Third is children. Breaking bad news to the parents is very, very, difficult because we have a pediatric oncologist here. We most of the times converse on these lines that breaking bad news to the children. But the children, one good part is that, most of the cancers have a higher cure rate than in adults.
Why is that?
No, that is because children, they respond well to the treatment. And most of the things what we see in children, like for example, the blood-related cancers, lymphomas, we don't see more of cancers related to the habits. For example, smoking, tobacco, all that we don't see. So generally, they have a good thing. So that is one part is good. But otherwise, breaking bad news first time, this comes secondary. They have a very good prognosis. Your treatment is going to be this. That all is probably after a few days.
Right.
But first time telling to them is really, really difficult.
Cancer cases in the youths especially rising, or is it?
We are seeing sort of an increasing trend. It is not to panic. There are 2-3 things to it. One is because of the habits. So in India, use of tobacco and related products are still the number one cause. If you want to put what we say, why this cancer happened, most of the times it is because of habits. That is one. Second is genetic causes are there. Because of these genetic causes, most of the times what we generally see normally is breast cancer in early stages. Generally breast cancer we see after 40, 45, 50 and above. But we see certain group of people in whom breast cancer we see very early, in and around 30 years, 32 years. So then when we see why is that, these are the reasons. It could be mainly because they had some genetic defect or genetic pattern. Even colon cancers are sort of, we are seeing in the young adults range, 28, 30, 35, those adults range. Generally, it is a proven fact that generally they are aggressive if it is in that younger population. They do not respond that well.
Tumor cells.
In that young adults. I'm not telling about children, 20, 28, 30, less than 40. Some of the patients, they do not do that well. That is a known fact.
So you mean treating cancer to that age group is really hard compared to the rest of the age group?
Correct. When we treat cancer, there are multiple other things. So if he's, for example, if he's only breadwinner of the family, if he's been diagnosed with cancer treatment is relatively longer. So you have surgery, you have chemotherapy, you have radiotherapy, immunotherapy. If all these are needed for a patient, it may take few months. So till that months, 6-7 months, no one is taking care of the, family or the in and around his home. So all that factors we do have to pitch in when we talk about.
So talking about family history, how much should it worry people?
So generally, all cancers do not generally run in families. what we usually see mainly is breast cancer, ovarian cancer, some amount of pancreatic cancers, prostate cancers, colon cancers. These are the most common, cancers that we see running in families. If a breast cancer lady has been diagnosed with certain form of breast cancer, generally we call the technical word as triple negative. So what it basically is, I'll just explain in one minute. So breast cancer, majorly there are 4 types. I'm not telling about the stage. Stage 1, 2, 3, 4. Breast cancer, basically there are 4 types. One, what we call as hormone related. That is because of the hormones in the body. Because of that, the cancer has developed. Second, within that only there are 2 types. Then the third one is what we call, there is a particular gene, what we call HER2, HER2 new, what we call it. If that gene, there is some defect in the gene, it can lead to breast cancer. If these 3 are absent, then the 4th one we called is triple negative. That is, all these 3 things are negative. So triple negative breast cancer run more in the family. Because in hormone we know it is because of the hormone. In HER2 we know.
Hormone means birth control.
Yeah, estrogen
pills,
related hormone.
Imbalances.
Yeah. So hormone, if the hormone levels are higher in the body, so then the chances of it developing breast cancer is more. See, when you tell hormone, to how much period the woman is exposed to an increased estrogen or a hormone, that can happen 2 to 3 reasons. One is an early menarche. Generally, females, they have a menarche or start their menses around 10 to 12 years. If suppose a female start their menarche periods by 9 years, 8 years, and the menopause is when they stop, their monthly periods. Generally, that age group is around 40, 42. If that continues and stops after 48 or 45 years, so you see the total amount of years that lady is exposed to this particular hormone is more. So in those reasons, it can be there. Now that can be because of many other things. Patient could be, the person could have having some, like you said, genetic condition, or some lifestyle changes, or some, medications. So because of all that, if the hormone levels are higher, it can lead to hormone related breast cancer. HER2 is again like a gene, like how we have multiple genes in our body. If there is any defect in the gene, it can lead to HER2 related breast cancer. If nothing of these is there, we call it triple negative. That is the sort of
that
more
means
aggressive.
Runs in the family.
That is what we generally see in the families. So then what researchers did is that, they took family histories of all these patients, and they, started running, like I said, the molecular tests and other things to see, is there any particular gene that they can identify. So there were multiple genes that were identified. In that, one is called BRCA, that is the name of the gene, that has been found to be very highly associated with breast cancer. BRCA 1 and 2 types of gene. This is a little bit technical, but still, then they found out that, BRCA gene, if anyone is having, they are very, very high risk for, cancers. You would have seen Angelina Jolie, there's a story behind that. So these BRCA genes run in the families. So if anyone is having this BRCA gene positive, it means that they are at a higher risk. Not that everyone will have, but definitely they are at a higher risk for, breast cancer. So now what we do is, if any patient of such, histology comes to us who's fitting into these profiles, we send them for BRCA gene testing. If it comes positive, then we counsel the, their daughters or their family that this is positive. Generally, it runs in families. If she is having a daughter or a son, for daughters, it is better to screen for breast cancer or ovarian cancer.
At the age of?
For general population, screening starts at 40 years. In them, we tell you have to start early by 10 years, 30 years.
At 30, you have to start screening.
You have to start screening for because you are at a high risk individual.
Okay.
It is similar for other cancers also.
Gastro, GI.
If we know that certain genes are there in them, we sort of, advise the family. One advantage in India also is that all these tests, molecular tests that I was saying, probably 10, 20 years back, it was very, very expensive. It was not available everywhere. But now it is more expensive, and because more and more research are happening, the cost also has sort of come down. So before it was more than 1 lakh 2 lakhs for
To
get
screen
that, not screening the best, for the genetic testing.
Okay.
Now it has significantly come down. It has almost 10 to 20,000 also they do it.
Even if you do genetic, I mean, it's a blessing,
Yes.
but also it makes them anxious.
Correct. That is the exact point.
Right.
Makes them that I was all fine. You doctor told me to do genetic this one. Now it has come positive. Now that positive doesn't mean that I have cancer. I may sometime in future I may get cancer. So why did you put me through all this?
Until then you have
you have that thing in the mind.
Right,
so then that's why genetic testing is not advised in general for everyone. In general, screening is advised because screening is a more valid, more focused test. If you see, we never advise genetic testing randomly.
Right.
It is very discussed with the family. If they are okay with it, then only we do it. But screening is not like that. Screening is a
confirmatory test.
Yeah, it is a screening tool by which we can sort of identify early cancers.
Okay, the screening and diagnosis are two different things.
Yeah, it is. Screening is generally done in normal population. So diagnosis is done in a patient. So what screening means that our aim is to identify cancers in an early stage. So there is no, ideally in first stage, yes. But whichever stage we identify, are we able to identify it early? Before the patient comes to us, can we identify it early?
Yes.
So
Let's talk about screening then.
He may have any stage. We are not bothered about that. We are only bothered whether we can identify it earlier. Preferably in a stage 1 or an early stage. Or
whose initiative is screening is? Like, is it patient's initiative or is the hospital initiative or government initiative?
So there are screening guidelines that is put up by the government, but they are not, mandatory. It is more of a patient's initiative. So screening basically means you come, get some tests done, which are so screening guidelines are there, which means that the test shouldn't be very, very expensive. It should be available everywhere and it should be easily done. So I cannot tell every patient to do an MRI for screening. So that is not practical. So what the doctors and the government, everyone has done is they have sat together and come up with the screening guidelines for the most common cancers. For example, in breast cancer, screening is done by mammogram. What is mammogram? Is simply taking X-ray of the breast. In that, we will come to know if the patient to feel a lump, it should be of some size. If it is very minute, some of the time we can pick it up early. If we have any doubt in that, mammogram or screening, then we order tests for diagnosis. So screening is done in general population who do not have any symptoms. So if a patient walks in saying that I want to do a screening of my breast, we do this and tell them that okay, everything is normal, nothing to worry, and then they can go back. So breast screening is done at the age of 40 years. Ideally, every year the patient is supposed to get a mammogram. Similarly, for cervical cancer, we have screening. In that, what we do is we do 2 tests basically. You can do either of the 2. One is called a pap smear. So wherein we take a small sample from the cervix and send it to the lab. Also, we send something called a HPV DNA. Why? Because cervical cancer, 99% is caused by a virus called HPV. So we test for that. So for cervical cancer, you have to start from 21 years up to 65 years. If you are doing a pap smear, like I said, you have to do every 3 years. If you are doing HPV, once in every 5 years, it is enough. You can do both also once in 5 years. Third, you have lung cancer screening, something called a low dose CT scan. So generally what CT scan we do, not that normal CT scan, in which a very, very low dose is used of CT to screen it. Fourth, we have oral cavity cancers, that is mainly by inspection of the oral cavity. Once in 3 to 5 years.
Inspection of mouth, what do you guys look for?
Yeah, we look for any changes, what we call as pre-cancerous lesions. If there is any white, plaque which is not going on brushing or touching it, we call it technically leukoplakia. If it is a plaque is red in color, we call erythroplakia. Then we examine all the neck and all regions and see if there is any problem. If we are suspecting anything, then we order further tests. That comes the diagnosis part. If everything is okay, then we send back the patient.
So we covered breast, HPV, mouth cancer,
lung cancer. Again, lung is done not in general population. Generally, who are smokers Only in those targeted people we do it. So these 4 cancers we have very good screening guidelines. Additionally, we have for prostate cancer, we have a blood test called PSA. Similarly, for colon and liver, stomach, we have few blood tests. But these are not very, very specific. We don't have that much robust guidelines as in breast and cervix. Breast and cervix is, the number one fixed, proven guidelines beyond doubt. So these will tell you that, okay, something is wrong. Probably you have to get evaluated.
And how much all these screenings cost?
Mammogram generally will cost in a general, say, a hospital setup around 750 to 1000 rupees. Pap smear will cost around 300 rupees. The PSA blood test again will cost around 300 to 400 rupees in a general hospital. Some government hospitals, it is done free of cost. So the idea of screening is that it shouldn't be very costly. So if I order the screening that is 40,000, who will do it?
Right.
So whole principle of screening is that it should be easily available. It should be very, very less costly. It should be convenient for the patient.
Right.
I cannot admit the patient for 5 days, do screening and send him. It should be quick. It should be very, very effective.
Do they look for just one specific type of cancer? I mean, are they curious about if they have any of the cancer?
Yeah, so that is one thing that probably we have not been able to address. There is no single blood test or single test that can, tell that full body, you don't have cancer anywhere in the body. So screening is more of site specific, that we have to screen for breast cancer, we have to screen for cervical cancer separately. There is no single blood test available in general, this thing. In some research setting, it is sort of there. But to tell it to the general public that, okay, you go and do this test, then I can tell you don't have cancer. We do not have that. It is because of the same reason. Every type of cancer behaves differently. Now, how a breast cancer behaves, the lung cancer will not behave that way. The brain tumor will not behave that way. Because each has different type of tissues. Each has different type of origin. So there is no way we can, tell with one blood test or one test that entire body you don't have any. Majority of the screening only for the most common cancers like breast, cervix, head and neck, lung. Why? Because of these guidelines that you are putting in an effort to screen. So if you are screening 1,000 patients and if you are able to detect 4 or 5 breast cancer, that is good. But if you go for a rarer cancer, you might have to screen 10 lakh people.
Right.
So that much machinery, that much workforce you cannot put in.
Right.
So that is why screening is done mainly for the common cancers.
So I'm pretty curious about probabilities, the statistics.
Yes.
So if you know any statistics, so which is the most common cancer, and we can rank
it,
come down to the most common to the rarest ones.
Yeah. So most common is breast cancer, be it in India, be it in world. Most common overall, if you take it, is breast cancer. In general, when we talk about India, we have oral cavity cancers coming second. We have lung cancers. Then we have cervical cancers. So in female, if you see, breast is first, cervical is second. Then after these head and neck, this thing, we have colon cancers.
Which is fifth.
Fifth. Then we have stomach cancers. We have brain tumors.
How about prostate? How
then
common
it is somewhere around that range. In that prostate comes in and around brain, prostate, that range. Then after that we have liver cancers, pancreatic cancers.
Those are very rare, is it?
These are somewhat rare, probably. And still the rarest is still below. Like we have something of the thyroid cancers, what we call kidney cancers. It is really not very, very common. Or these are rarer cancers, we can tell. Bone cancers. These are rare cancers, very, very rare.
Blood cancers.
Yeah, blood cancer is somewhere in the middle. Blood cancers and lymphoma, what we call, of the lymph node. These are somewhere in the middle of the pyramid. But at top is this, breast, cervix, head and neck. Right. These three are the most common cancers that we generally deal with.
So when somebody first comes to you with a suspicion of cancer, screening happens first.
No, that is what it is. Screening is always done in general population. For example, screening, we never do screening in a patient who has come with symptom. For example, who has come with say a certain amount of bleeding from the rectum or multiple oral lesions. That is not screening. Screening is done in a general population. So screening is not a confirmatory test for cancer. Screening basically what it does is it tells us whether the patient having some signs of cancer, but the symptoms have not come. Symptoms, the patient is not experiencing anything. For a patient to have any symptom, for example, cough or anything, the cancer should have grown to some particular size. It has not reached that size yet, but definitely something is looking wrong. So with that, what happens is, with that screening, next we go to the diagnosis. We tell the patient, okay, we have done your screening, but something looks suspicious. Let us get further tests and see. So screening is always done in a general population who do not have any symptoms. That is why generally screening is done in camps. Hospital, goes to a outreach initiative. They go to a place, they conduct a camp and screen there. Or they hold some screening camps.
How
in
successful
hospital.
are they?
They are actually very successful. In breast cervix, actually the sensitivity of the technical term is sensitivity, what we call that, how often we are able to pick up. So it is in 70 to 80%. 100 people get screened. If 100 people are having some problem, 70 to 80% of the times we can pick it up.
So when person comes with a suspicion of cancer, you straight away,
yes,
what is your next step?
Yeah, so next step, generally any patient comes with a suspicion of cancer to us. We do 3 to 4 verticals of things. One is called an history. That is, we ask the patient in detail, when did it start? What were the symptoms? Did you have these symptoms? With that, what we try to do is we figure out where exactly is the problem. So if the patient may give us a history, he has been, say, chewing tobacco from 20 years. From past 1 year, he has developed pain in the throat. From past 2 months, he is not able to take food. From past 1 week, he is having, say, something, is not completely able to take food, or pain has increased. So that gives us a sort of an idea. Okay, probably from 2 years is having problem. It is going on increasing. If you see he's not able to take food, then it has increased, pain is increasing. So a good history taking we do. Whether you had any family history, any previous history of cancer, any habits. That is the first part that generally any doctor will do. Second is called an examination, that we clinically examine the patient. Whichever site we are suspecting, if it is an oral cavity, we do a complete examination. If it is a breast cancer, we are suspecting breast cancer, we do a breast examination. If we are suspecting a cervical cancer, we do a cervix examination. Whichever area the patient has issues, we examine that completely and get an idea. Now, third thing is we have to confirm it. Now, it could be various things. With naked eye, I can probably suspect it. I cannot tell what exactly it is. So confirmatory test is something we call a biopsy. Biopsy simply means you take a small piece from that area and send it to the lab. In lab, what will they do? They will get the sample, keep it under the microscope, check for any cancerous cells. If there is any presence of cancerous cells, because cancerous cells we can see only in microscope. Once you put under the microscope, they stay in it, see.
Biopsy is confirmation.
Biopsy is generally the gold standard for confirmation.
Is biopsy painful or expensive, or both?
No, it is painful because we are taking a small piece from that area. Definitely, there will be some amount of pain, but it is generally done under local anesthesia. Generally, we do not give general anesthesia or anything, depending on the site. For example, if it is in the breast, a small anesthesia is given to that area and a biopsy is taken. It is done
if it's
on
in
OPD.
the gut?
If in the gut, they do something called colonoscopy. You have to get admitted, or on a daycare basis. They pass the scope, what we call a scope, that basically has a camera. If you're doing for the esophagus, stomach, going to the mouth. If you're going the rectum, colon, you go into the rectum. That camera has an additional port wherein you can pass a small biopsy needle or a forceps, what we call. It will go there, take a sample and send it to the lab. So again, it is not painful because anyway you're giving a small anesthesia, but it is generally an OPD procedure. It is not very, very complicated procedure. So once you send it to the lab, it generally takes 3 to 4 days for the report because they have to process it. They have to take out the sample. They'll then put staining, what we call that, to see the cells better. So generally plain, if you take and keep under microscope, everything will look same way. So there are some special dye or stains we put it, only cancer cells will pick it up, or other cells only will pick it up. So in that type, they will do it and check it under the microscope. That time they can tell properly what it is. So that takes 4 to 5 days. So biopsy is the one test that is done in generally all cancers.
Why is it a time-intensive process?
Yeah, why? Because the first day, for example, patient comes us to on a Monday. We will take the biopsy on a Monday, send the sample to the lab. Now in the lab, once they receive the sample, they have to process it, because we may send a big piece, we may send a very small piece. But when you're seeing under microscope, it has to be in micro to nano slices. So they have to slice it at that precision. Not all slice will be correct. Some may be just the surrounding tissues. So each and every slice they have to see whether it is a correct slice or not. So once they get the correct slice, then they stain it. So everything looks plain otherwise. If you have to see particular cancer cell, they have to stain it and keep it for some time, 24 to 48 hours. For that, the cancer cells take the stain and other cells do not take the stain. So all that procedure takes 3 to 4 days. Generally, within 4 to 5 days, we get it.
Right. So do you get to see the stage of the cancer also through biopsy?
No, we don't get to see from the biopsy. Biopsy, we get to see, one is whether it is a confirmatory, whether it is cancerous or not. In the biopsy, we get to see sometimes the grade. Grade means how fast it is multiplying.
So how can you understand a grade?
Yes.
Just throwing a screenshot of a tissue.
Correct. Why? Because we get to know how fast the cancer cells are multiplying. So that will have certain features within the cell. So if it is a grade 1 versus a grade 3, the number of dividing cells, what we call. So number of dividing cells in the overall, say what you told screenshot, maybe just 2 in one patient. But if the number of dividing cells, what we see, if it is more than 1,000, it means that it is a higher grade. So number of dividing cells.
So grade and stage are two different
things. Okay. Grade is basically telling us how fast or how fast the tumor has multiplied. Stage is not. Stage will tell us the location. So grade, I can have a stage 4 cancer with grade 1. I can have a grade 3 cancer with stage 1 also.
Oh, so many
both are independent.
There, right?
So one is how fast it is multiplying.
That is dangerous.
It is not dangerous. It is just a concept. So the grade 1 definitely is slightly better. It means that cancer cells are slowly multiplying. Grade 3 means it is multiplying little bit faster. So again, it is a technical thing. Stage, on the other hand, will tell you whether it has gone to any other areas or
other
not.
Locations.
Other locations. Stage 1 generally means it is in that same location. Stage 2, just it has breached the surrounding area. Stage 3, again in that similar surrounding area. Stage 4, to other areas it has gone.
So biopsy would tell you the grade of the
grade
cancer.
Of tumor.
And
mainly it will
confirm the patient as a tumor.
Yes, and also one more thing, it will tell us which type of it is. For example, we have multiple types of cancer. To be technical, we sometimes call it squamous cell, adeno, all that you would have seen in the report. But we will not go that technical. So what I'm telling is there are around 20 to 30 types of cancer. From where it has originated,
which cell
it has,
type. Okay.
Correct. So that also we'll get from biopsy.
Why that matters? Why that information?
Because our treatment will matter. So whichever cell the cancer has come, our treatment also is directed on that line. Otherwise it will not work. That time I told you about the 3-4 types of breast tumors. So if we treat a hormone breast with the type of say the triple negative, it won't work. So mainly for us to treat it will guide our treatment. If this having this particular cell type, that means our treatment should be directed towards that type. Second is, it will tell us the prognosis also. How is going to be the outcome?
What's prognosis?
Yeah, prognosis basically means if a patient is having, this particular cancer, this particular cell type, this particular stage, then what is his outcome going to be? What is his survival going to be?
It's like prediction.
Prediction. So how, his cancer is going to respond to our treatment. We can sort of predict that. May not be 100%.
Is it computation or just discussion with your colleagues?
It is. We have proven, we have also algorithms, certain algorithms that we can use to predict. But generally it is based on the literature that is available. Whatever is there in our whatever is reported in our oncology community. First step is we discuss with our team. So some things by experience. Second is the teamwork, that I may know some part, but I may not know everything. So we discuss with our team that this is the thing, this is the thing. Over that, if we have doubt, again we go back to literature. We all do a literature search, especially we do when it is some rare cancer coming, like we have not seen in off late much here. So if such cases come, or some tricky cases, the cancer has come back again, how do we proceed? All those cases we discuss. Or that is called a tumor board. That is the word what we generally use. So
how many people would be in the tumor board?
Generally it includes radiation oncologists, surgical oncologists who do the surgery, medical oncologists, pathologists who will report the biopsy, as I tell you. More radiologists, the one who we do the scans. So they will report the scans. They are involved. Then it also involves our other departments, supportive departments, such as physiotherapy, speech and swallowing department, nutrition department. So around 10 departments are generally involved in the care. Because what we do is we discuss the patient in the tumor board. We tell, okay, this is the problem, this is the issues, this is what we are supposed to do. And then we come out with the treatment outcome. That this is the plan, so I have to be involved. Meanwhile, I'll involve the nutrition also. We discuss that, okay, you have to do this for the patient, you have to do this for the patient. Then we chart out a plan and everybody has to follow that. That is in general what we call a tumor board meeting.
Do you also figure out how much it would cost, and that you guys communicate to the patient as well upfront?
Yeah, so generally what happens is in tumor board, soon after the tumor board, even the patient attender will be there. So we all sit and discuss with them. Sometimes even we call the patient attender to the meeting, because they may not understand what we are sometimes discussing if it is too technical, but we involve them also. Or sometimes immediately after the meeting we call them and tell them that this is the things and this is the thing, this is the probable expense that you are going to have. And also it is very important to tell them at what time points what expense might come up. For example, if a patient may have chemotherapy today, they may go on for 3-4 months. After that he'll have probably surgery. So it is very important to tell them that, okay, today you may have these treatment, but on that day, probably in March, April, you may have to undergo surgery. That time you will need a few days admission, you will need someone to take care. Also you will need probably this much amount and everything.
So biopsy, so that's why this takes time.
Yes, because we have to be very, very sure, because sometimes what happens, I told you that it may mimic something else. It may not be cancer, but it looks like cancer, feels like cancer. But when we send finally, it may not come cancer. It may be because of something else. Breast, usually it happens that every breast lump is not cancerous lump. There is something called non-cancerous breast lump. Actually, that is more commonly seen. So if they have a breast lump, it may be because of the fat, it may be because of the muscles, it may be sometimes because of some infection. So most of the time breast lumps may not be cancerous also. To confirm it, we do the biopsy. Now the last part in that vertical, first I told you is history. We do a physical examination.
Yeah.
Third I told
scans,
you
where those
that is the fourth
okay,
aspect.
Scans come later after biopsy, is it?
It sometimes it can go hand in hand. Generally it can precede the biopsy also. For example, if it is a breast, directly if you are able to take, we can see and take it. But always it is better to get the scans before.
If you are doing biopsy first and then scan, and biopsy would give us the 100% confirmation of the cancer.
Yes.
Why do we have to do the scans?
That is, we do the scans to see where all the cancer has spread. So when I see by naked eye, I may be, suppose in the oral cavity, I may be able to see a swelling or a lesion in the oral cavity. Now I don't know inside how much it has gone, surrounding areas how much it has gone, we cannot know. Because with naked eye we cannot see that. Or if it has spread to any other areas, we do not know. That is why we do this radiological investigations, what we call in general words scans. Now that can be anything. It can be an X-ray, it can be a CT scan, it can be a PET CT, it can be a MRI. So different, depending on the type of the cancer and the location, we order the most suitable test. It is not a one blanket fit all. So for brain we cannot do brain, we have to do an MRI most of the times. We cannot do an X-ray of the brain. So it is depending on the location. More importantly, what type of cancer is it and where the exact location is and what we want to see there. So scans will give us two information. One, it will tell us how, locally how inside it has gone. Second, any other areas are involved or not. So these two information will give you. So with now all these four verticals, that is your history, examination, scans and biopsy, we will finally come to a sort of a conclusion that this is the cancer that particular person is having. This is the type of the cell. This is the biopsy confirmatory thing. This is his stage. These are the locations where his cancer is. And then based on that, our next treatment line starts. So in scans also multiple now newer scans have come. Before mainly it started with X-rays. Then came ultrasound, then CT scans, then MRI. Now we have PET scans, then we have bone scans. We have multiple scans to cover the,
Why
body.
so much variation?
Because whatever the scan detail tells us, it varies according to that. For example, if you just want to see, if you take an X-ray, it will just tell us that there is some, opacity, something in the X-ray. If that is what we are looking at, that is enough for us. For example, if a person of say TB or say asthma or some lung condition comes to you, you have started the treatment. You just want to see how he is responding. An X-ray is more than enough. But particularly for cancer, you want to see where all it has spread. So in those cases, we have to order these scans. Within the scan, some areas they are seen better in an MRI. For example, our soft tissues, what we tell, like our brain, tongue, our pelvic region, wherever there is a muscle, those regions are seen better in an MRI. But wherever there is bone, CT is better. So mainly depending on the type and depending on what we want to see, our scan varies. That is why different types of scans are there.
So the diagnosis would take the whole four things around a week to confirm if it's a cancer.
Yes, it takes. We can do parallelly. We don't generally wait. If we are suspicious, we don't, take history today. You come tomorrow for examination. We don't do that. We do history, physical examination. Most of the times biopsy or the scan on the same day. Meanwhile, scan report generally comes, 1 day, 2 days it comes. It doesn't take that much time. Biopsy comes in 3 or 4 days.
Biopsy and discussion in the tumor board conclusion.
That takes, about a week. About a week if everything is on time.
How important is clinical examination in a scan-rich world? Like world is full of scan.
Correct.
So if you're doing scan, why do we do clinical examination?
Correct.
And do we need clinical examination?
Oh, you need. Because that our entire medicine for that matter is really, based on clinical examination. Now I will do a scan only if I suspect something. So when I touch the patient, when I, examine the patient, that still gives me a first-hand idea of what actually is the thing going wrong. Now, I may touch a breast lump or a cervical or a neck lump and see, okay, today this is the size. Now, when I start him on treatment, after 1 or 2 months, when I again examine and see, I will remember that, okay, that day it was like this. When I touch today, it has come down or it has increased. But if I do a scan, I am not really, involved in that.
There's no human involved.
There is human involved.
I was predicting in the future, there won't be any doctor. I mean, you just straight away walk in and scan and robot will tell you.
Could be.
But clinical examination is very, absolutely
very important. Because most of our teachers also, they focused most of the things on clinical examination. Because just by seeing the patient, with history and this one, they could tell, this is the problem.
Right.
We can most of the doctors do it today. It is not like they are not doing. But definitely, like you said, the scans have also increased. because of the increase in technology.
But
History
the
taking.
doctor's capability to clinical examiner also has come down, I guess.
That is again a controversial statement. But again, in our curriculum, if you see today, because we in KMC we teach the students also, curriculum also strictly, even now the focus is on clinical examination. But like you said, because of various factors, probably it is going down. I should admit it. It is not it is a known fact. It is not like a secret or something. So we need more and more things to focus, because every day, if it shouldn't be like this patient walks in, you write and give some test.
Right.
Professors used to tell, like stethoscope is the only device that touches millions of hearts.
How would you understand someone's health through listening through body noise?
So every disease, for that matter, will cause some irregularities or imbalance in the body. Using stethoscope, what we generally hear are the sounds, like you said. So if a person is breathing normally, there is a particular pattern of sound. So when he inhales and exhales, when we put our stethoscope and keep it to the chest, whichever area, and there are multiple areas also. So in lung, there are, what we call inframammary, supraclavicular, so multiple areas are there. So each area has a different sort of a sound.
I think I should do a podcast on that. This is very interesting.
So then after that, what happens, if the patient is having some disease, if he is having some blockage in the lung, we hear a different voice. If there is some water in the lung, because
that happens in the clinical examination after diagnosis also.
Yes, it happens. So if he's having, say, lung cancer, if one part there is a complete blockade, we cannot hear it moving. That means that air is not properly entering.
Okay.
It is similarly for the heart also. You would have seen cardiologists or physicians, they keep the stethoscope in the region of the heart and examine, because heartbeat also there is variation. So if a patient is having some defect in the blood going through the heart, when that passage happens, some sounds are produced. With that, we are able to pick up. So clinical examination is very, 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 very important. So touching with our hands, examining the patient, using the stethoscope, observing, everything makes a lot of difference in how it is done.
Yeah, I mean, one of the biggest complaint patients have is like they always wonder why so many scans are ordered.
Yeah.
His hospital is trying to make money out of his.
No.
So now it's justified.
Yeah,
Why?
it is justified, because we need to know before, because cancer, like I said, it is a condition where we have to be, one is we have to be very, very sure that we are treating cancer. Second is always treating cancer for the first time is always, when we have to treating for the first time, we have to always treat it as good as possible. So if you are having a common cold, you treat today. If a common cold comes back after 1 month, again you can treat it. But cancer is not like that. Once you treat a patient completely of cancer, if the cancer recurs, treating it is always difficult. It is not same as we treat it for the first time. So first time is always the best time. So you have to be doubly sure that we have not missed out anything.
Accuracy matters.
Second, mainly is that we have not missed out anything and we are treating the right thing. So all these things really matter.
All right.
Yeah, that's why these tests are done. And one more point of view is that nowadays when we have technology, we sort of can use it to our use. If I have a scan, the CT scan available, if I want to, confirm one thing, we can definitely use it rather than, not confirming it.
Right.
But having said that, unnecessary scan also should not be done. That I agree.
People get scared of biopsy as well, no?
Yeah. There are 2 to 3 myths also that when you do biopsy, cancer can spread. So generally it is not the case. So there are some cancers where, we generally do not advise biopsy if we are suspecting, it may leak out or something. So for example, if it is a very early ovarian cancer, we generally do not do biopsy. We ask for directly surgery. If it is within the brain in certain areas where we called where our entire body's respiration is, there we do not ask for a biopsy because that will cause more harm.
Right.
Apart from that, a biopsy, it is a painless procedure because we give a local anesthesia. It will not spread the cancer because if you are doing a biopsy, we are just taking a small bit. If the tumor is 10 centimeters, we are taking a very, very small bit.
Now I want to understand cost.
Yeah.
Cost of diagnosis.
Yeah.
So what is the range we're looking at? Where there is variation and what causes variation in the cost?
Yeah. So generally in India, for that matter, we have 3-4 types of setups. One is called a government setup, wherein the hospital is completely managed by the government. It can be like our AIMS, numerous AIMS across the countries. It can be regional cancer centers, that is each state has 1 or 2 centers. In Karnataka, it is Kidwai.
In Bangalore?
Bangalore.
Okay.
For Kerala, it is RCC Trivandrum. Mumbai, it is Tata Memorial Hospital. So each state has more or less one regional cancer center. Some states have 1 or 2.
Okay.
These are the second line of hospitals that we have. There only cancer patients are treated. Government hospitals generally, for example, like our Venlock Hospital, or in Bangalore Medical College, Victoria Hospital, there any person can get treated.
Right.
Third is the medical college setup, like Kasturba Medical College. In Mangalore, we have multiple: Shema, Yanapaya, AJ, Father Mullers. So these are a medical college setup. The fourth is what we call the hospital group or a corporate hospital.
Private hospital.
Corporate hospital setup. These are the 4 to 5 verticals of hospital that we have.
Interesting.
Yeah. So the cost varies the lowest to the highest in this order only. Mainly because of different things. One is the government institute, it is managed by the government. So facilities, most of the things are are done for free. But definitely some cost will be there. Minimal charges are taken. Medical college setup also, the costs are less when compared to a corporate hospital. Corporate hospital, the costs are
the state-run hospital is also free as compared to,
yeah, state-run generally it is free. Generally it is free, but some, that's what free means. Some it is, no hospital is 100% free.
Right.
Some charges they may take for certain high-end tests.
Affordable.
It is affordable. So what it is, more of a subsidy. For example, if I'm doing a CT scan, you have a particular cost. So, for example, let us take it is 2,000 rupees. Now, the 2,000 rupees in a government hospital, it is, say, it will take it for free. So, the government is paying that money.
Right.
So, in a medical college, even if it is not 2,000, it may be around 1,000 or 1,200 rupees. The remaining amount, colleges, the medical college setup or the college setup is paying for it, because to benefit the patient. Whereas in a corporate hospital, it may be around 2,000 only. They may not do it for less because of they have invested their infrastructure into it. So it is mainly, there is a cost involved. Who is bearing the cost? How much percentage of the cost government is bearing, so that the patient have to pay that much. If it's a medical college setup, how much percentage of the cost the medical college is bearing. So these are the 4 verticals that we see. Now, when I say biopsy and other tests, so in government hospitals, it is done most of the times for free or at a very nominal charges. The instrument charges may come, maybe 100 to 200 rupees, that's max. In medical college setup, it may be around 500 to 800. Sometimes the biopsy, if it is very deep, suppose inside the lung, inside the body, we cannot directly do. We have to use either a CT scan or an endoscope or a bronchoscope and do. In that cases, it may be 2,000 to 3,000 rupees. Same in the corporate, when we are talking, it may be around 5,000 to 6,000 rupees in that thing. But overall, it is not a very, very expensive test. It is done on OPD basis test.
Are there any ways families can prepare beforehand, like plan better or to avoid unnecessary expenses here?
So what a family can do is, first is, discuss with the doctor that what is their timeline of diagnosis going to be. That you have gone to the doctor, they have done the examination, have an open conversation with them, with the doctor. Most of the time, doctor will tell you, if not also better to talk to the doctor that, okay, you are suspecting this, doctor. What are the general tests that needs to go and when should I probably do it? And what is the cost involved for it? So that is always good to have a discussion with the doctor. That will keep you updated about what are the finances that is going to incur. Because we talk very less about finances sometimes.
Right.
So finances means, what I'm telling is financial planning. That is what I meant. if we tell the patient, or if the patient is sort of updated about the financial planning, then I feel that they are at a better place to they come back and adhere to the treatment better. Most of the times what happens is suddenly they realize that okay, expense may come up, then they sort of don't come.
Right.
So if they are well prepared that these are the things we need to do, we have to do this, these are the treatments that is planned, these are the probable expenses that may incur beforehand only, that is always better, I feel. One main thing is that talk to the doctor, get a first hand idea of about what is happening. Second is involve the family, or your friends. If you are staying, if you don't have a family with you, or say because of various reasons they are not here, they are staying in away place, you are working here, involve your friends also, because moral support is very, very important. You have been diagnosed, or your family member has been diagnosed, you being there for them, that itself is a very, very thing. So first thing is, obviously, even if tomorrow if someone tells me that I have some disease, I will also get panicked. And sometimes that panic to some extent is normal. We cannot expect anyone that you tell a very, very big news, a bad news, and expect him to behave normally. Oh, okay, chalo, let's do this. So always that panic or that anxiousness in the initial phase, it is okay. More important is how you treat them during that phase. You comfort them, tell them that okay, this is there. We know that this is there, this has happened, we cannot undo it. More importantly, let us face it, let us take it forward, let us do the right treatment, and doctor has told that it can be done, so let us take it in that way. Don't worry, we are there for you. So that itself, it is like an invisible force. Patient may not, there is nothing written in document that he is going to support me, no one writes and gives, but being there for the patient by his side,
moral
that
support.
itself we have seen. Because moral support, we do not document it anywhere. That is why we don't have data that this patient told like this. But that makes an invisible difference in a subconscious mind to the patient. It makes a lot of difference. That is what
mindset also matters.
Mindset
no?
definitely
Patient
matters.
mindset.
How to get that patient into that positive mindset. Most of the times, immediately it is not possible. Like I said.
Have you seen positive mindset making a huge difference in
definitely.
cancer patient?
Yeah, I have seen. Personally also I have seen. What happens is, because of positive mindset, what happens is, they stick to the treatment better. That is what I have seen. They complete their treatment on time. They do not, neglect the treatment much. And this would be not in every patient, I would say, but at least 30-40% of the patients I have seen that who have a generally positive outlook, they generally end up supporting other cancer patients also. So
why is it difficult to stick to the treatment plan?
one is, as I told you, they get too emotional, or they have this fear of having that if I take the treatment, what will happen. Second is fear about the treatment. Now, chemotherapy, surgery, radiotherapy, when we tell about cancer directed therapies, as we term them, they have a little bit their own side effects. So once we explain it to them, for example, certain chemotherapies, there can be hair loss. For a young woman in 40, how we can think,
Devastating.
yes, it is a devastating. More than the cancer, this is sometimes more for them. Third is what will other patients think. Radiotherapy generally is given for 30 to 35 days. Daily they'll have to come either from home or admitted. How will I come? What will I do? If I come for my treatment, who will handle the family? Because it is tough. Oncology is tough, both for the patients, for doctors also to an extent. We deal day in, day out with these sort of issues, a lot of personal issues, family issues. So they open up to us. So oncology is not a very easy department to be. For that, any department I wouldn't say is not that, but per se, we have a lot of personal touch with the patient. The patient comes back to us for life. Like every time, even after treatment, they keep coming back. So in other specialties, they don't come back that often. Because if you have diagnosed with say malaria or a dengue, You come, you treat, probably you won't come back for a malaria re-examination again. But oncology cancer treatment is not like that. They always come back to us. So that lot of hope. They also expect our doctors also to be positive. So most of the times they are not okay if we tell them that the cancer is 4th stage, or if the cancer has come back. They expect us to tell in a positive way. And sometimes we have seen that in my cabin, when we in the OPD, the first family comes, patient will be sitting outside. So by that time only they'll get full anxious. So all these things are there, minute things are there which we sometimes overlook. So patient will be sitting outside and family members will be discussing for 15-20 minutes, sometimes up to 1 hour in our cabin. So all this while patient is simply sitting out. That itself sort of makes them jittery. So it is there. All these things are there.
Since you have studied economics of cancer care, I think I let you start the conversation and guide me through. I'm pretty curious. Yes.
Yeah. So when we talk about economics of cancer care, basically we have to see 2 to 3 components. So we are probably not here to discuss the cost, discount, particular hospital, because there are multiple hospitals and multiple everything. So we'll not go much into that. What I am telling is how the patient can be informed much better and what are the avenues that are available. That is, I think, more important.
I also want to focus insurance, government schemes.
Okay. All those avenues. For example, the government avenues that are available.
That's one. And then also
private insurances that are available.
Variations in cancer, like why
the variation,
cost variations in the cancer types and those things. Yes.
Correct. So generally when we talk about the cost of cancer care, in simple words, the lesser is the treatment needed. So why is it? Because earlier stage have a very good prognosis, and generally the dictum or the the thing is that if it is a very early stage, then single modality of treatment is the treatment of choice. For example,
what is modality?
Yeah, so modality of cancer treatment, it means it could be either surgical, it could be radiotherapy, it could be chemotherapy. These 3 are the main pillars of cancer treatment. Now within surgery you could have multiple subdivisions, like you could have a open surgery, you can have a laparoscopy or a minimal invasive surgery, robotic surgeries could be there. Radiotherapy also, there are multiple techniques. We give radiation from the outside. Some radiation, what we call brachytherapy, we give from the inside. Chemotherapy also, there could be multiple. It could be hormone therapy, immunotherapy, or plain chemotherapy, some tablets. So within these 3 pillars, there are multiple types.
Or again, combination of these 3.
Yeah, combinations. So main 3, surgery, radiotherapy, chemotherapy. These are the main 3 pillars in general. So if it is a stage 1 cancer, generally most of the times one modality or max to max 1 or 2 modalities will be enough. If he is having a very small lesion, if you just do surgery, it might be enough. But that is not the case once it comes to stage 3, stage 4. In stage 3, even if you do surgery, the chance of it coming back is high. So that is why we advise further treatment, that is radiotherapy, chemotherapy. So in those cases, what happens? Additional treatment, all these treatment, it is called as multimodality treatment. So single modality versus multimodality treatment. As soon as your multimodality treatment comes in, that is 2-3 types of treatment has to be given, your cost also escalates. And not only that cost, when you're planning chemotherapy, it is for few months or few weeks. So additional cost of, their stay, etc., it goes on
post-care,
adding. Yes, post-care, follow-up care. There could be some side effects of treatment. Because of that, they can happen. So that is why these cost differences mainly come. One type of treatment is enough in some cases. Second is probably one type is not enough. 2 to 3 types of treatment needs to be given. Second aspect why cost increases, there are certain, like we discussed that time about the moleculars and genetics thing. Of late, there are a lot of molecules and lot of treatment available that is directed at these molecular genes. For example, that time we discussed about HER2 new in breast. So there is now treatment available if the patient is having a HER2 positive breast cancer, but that is again going to add on to the cost. So that is why whenever there are multiple lines involved, that is why the cost also escalates. Now, cost again, there are two parts of the cost. The majority of the cost is, I would say, three parts. One is pre-treatment cost that we discussed that time about diagnosis, the scans, and everything. Second is the treatment cost, that is surgery, chemotherapy, radiotherapy. That is it. Third is something called as out-of-pocket expenditure. That is something we call as invisible cost. That you are coming, for example, say from Shimoga to Mangalore for chemotherapy. You have 8 chemotherapies to be taken every month. For example, take it as one chemotherapy. So you are coming for chemotherapy only on one day. So that one chemotherapy cost is definitely involved. But when you're coming on that day, your bus charge is there. You have to go back. When you come here for 1 or 2 days, your food charges are there. You have to, at least have breakfast, lunch, dinner. Along with you can't come alone. At least somebody will be there along with you. Their charges is there. And these 2 days, neither can you go for work, neither can other person go for work. So all these charges are called out-of-pocket expenditure. That is not exactly related to the treatment, but these are necessary cost, which is very less talked about. And we generally don't realize it. So it is become like a part and parcel.
Right.
So this is a third, one more important domain that we see. When we talk about avenues, so now there are multiple government-led initiatives throughout the country. There is something called as Ayushman Bharat program. That has the liberty is given to the state to sort of modify it and fit in according to their requirements. In Karnataka, it is called Ayushman Bharat Arogya Karnataka Yojana. That is again a center state, Yojana, but it is led by the state government. So all health initiatives are generally led by the state governments. So in that, what do they tell? They are basically asking you to make a Ayushman card that can be done just based on Aadhaar card. Once you do the Ayushman card, you are eligible up to 5 lakhs of insurance from the government. Now, this 5 lakhs is not blanket. So once you do the Ayushman card, again, what is the step in that is if you are belonging to a below poverty line or a BPL ration card, you the treatment whatever available in Ayushman Bharat, it is given for free. Similarly, if you belong to an APL card or APL ration card, 30% of the treatment cost will be borne by the government, 70% you will have to pay. So that is a differentiating factor. That is the government rule. Everyone knows it. So how do you make this Ayushman card is you have multiple options. One is to either go to the district hospital in whichever district you are in and apply there, and they will get you the Ayushman card. Otherwise, in some government designated centers, there also they make the card. Now, what is the workflow or what is the how does it work is, suppose if you are having any disease, ideally you have to go to the government hospital. That is a rule. If you want to avail Ayushman facility, it is mainly driven by the government hospitals. For example, in Mangalore, you will have to go to say Venlock, or in your district Udupi, you have to go to Udupi district hospital. If you are in other district, you have to go to district hospital. So they will see you, they will evaluate you, and they will probably do the initial workup, whatever I told you. Then they will come with the final plan that this is the treatment plan. Now, if the facility is available there, they will advise for treatment there only. For example, X and X patient, they want, they have diagnosed of a breast lump. They have to do a surgery, breast surgery. It is done in that particular government hospital. So they will do it there only. But if the facility is not there, they can refer it to any other hospital. So they cannot refer it to this particular hospital. It is the patient's choice. So we have a website that is called SAST, SAST website that is run by the Karnataka government. In that, all details are there. Whichever hospital are empaneled in that, every details are there. So generally what happens if the facility is not available, for example, radiotherapy is not available, they don't have the equipment there. So they can refer the patient to either higher center. That which higher center, patient can decide. There is no hard and fast rule that they have to come to particular center only, they have to go to this only. That is the government scheme. Advantage of that is, for example, if the facility is not there, for example, radiotherapy is not there in say district hospital, they can come to other hospital. They can come to other hospital and avail the same care under that same scheme. So if a hospital is empaneled to that Ayushman Bharat Yojana, The patient, if is a BPL card holder, the patient can get free treatment, completely free of cost at the treating hospital. They are not supposed to charge patient any of the cost. For this, one requirement is that your majority of the patient, what I've seen in last 2-3 years, they know about it. They have a brief idea about this, but the certain nuances they need to know, so that at the last moment, few patients we have experienced this, that particularly in Karnataka, because each state, what they have done is, this is a broad Ayushman Bharat Yojana. Each state have sort of, permutation combination, and each stage has a rate code and a package code, everything for each specialty. It is not restricted to oncology. You have anything. Only thing, your hospital should be empaneled to that particular facility. If your hospital is empaneled for oncology, you can treat oncology patients. If your hospital is empaneled to, say, surgery, you can do surgery patients. So depending on that, it is given. So some issues that we generally see that patients tell us is that they wouldn't have linked their Aadhaar and ration card. That is the most common issue. Or their ration card has expired. They have an Ayushman card, but they don't have this ration card. So all these problems, hospital cannot do anything. It is a more of a technical issue or a government issues at that level. So neither than the government can bypass it, neither can we bypass it. So my advice is, if you are having an Ayushman card any one of can have. I can have, you can have, anyone can have. The differentiation factor for the cost involved is a BPL or the APL. That again is decided by the government. Hospital has no role in it. So whatever the patient is having, the hospital provides treatment according to that. For example, if say radiotherapy is 1 lakh rupees, or in that Ayushman code it is 75,000 rupees. If you are a BPL card holder, you that complete 75,000 rupees is borne by the government, and patient is not charged anything if you are from the BPL card holder. If you are an APL card holder, 30% is covered by the government. That means
out of 75.
Around I think 48, 45 patient will have to pay. So that is the general scheme that is there. So always it is better once to check if you have an Ayushman. If you want to avail the facility under this particular scheme, check if you have an Ayushman card. If you don't have, get it one. If you have got it one, check if everything is linked.
And how long does it take to create one?
Generally,
can it be
no.
created in the hospital itself?
In hospital, no. It is done by the government. So it is done at the government center.
Hospital, okay.
Either at a district hospital or these centers where Ayushman or health centers are there, designated by the hospitals.
Patient has to register Ayushman card before admitting the patient.
Yes.
Or not at the billing stage of the...
No. That is one more confusion, because everything is done based on a cashless facility and a pre-auth facility. So what happens is, that is the second part. So once you have the card, you go to the government hospital, they tell you that, okay, this facility is there, you can get it done there only. That they cannot refer outside. Because facility is there, how can you refer outside? But for certain facilities, it is not there. They can refer to other centers. For example, this patient has come here. So what we do is, we apply a pre-authorization form to the government that this patient is come, this is the plan of the treatment, and these are the codes that we have certain codes put. So we are applying these codes, and this treatment will be done. We apply it to the government. Before, used to take a lot of time, 7 to 8 days for the approval. But now it is all digitized. Everything is good. Within 3 to 4 days or maximum 3 days. Generally, we get 1 or 2 days only. Maximum 3 to 4 days, we get the approval from the government. It is again an online portal. Patient also can check what is the status and everything. So we upload it today. For example, this treatment is there. And this is, and patient also gets an intimation on his mobile phone if it is linked. After 2 to 3 days, the government gives approval. Okay, we have verified all the documents. So the documents, what they generally ask is, that's what proof. One is a biopsy report, one is a scan report, and one is the form, our form stating that treatment is so and so. Tumor board form, what we call. So these 3 documents are generally asked. And then it is uploaded to the government portal. Once approval comes, then we start the treatment. If approval comes today, generally then we schedule the surgery maybe 1 or 2 days after taking everything. We schedule.
So there is no urgency in cancer care.
It is not an emergency treatment, but it is an urgent treatment. So what I mean by emergencies are like for example, heart attack, MI. That is an emergency. You cannot wait.
Right.
Like you cannot tell that, okay, you come after 2 hours. Or if the patient has met with an accident, he's having blood loss. These are emergency treatments that you cannot wait. The more and more minute you wait, the more and more mortality chances. Cancer, most of the cancer for that matter, it is not an emergency treatment, but it is an urgent treatment. Urgent means you are not supposed to delay it.
Right.
But most of the times, immediately you, if you start, you can very well, you can start. But even 1-2 days gap, it is okay. But there are certain conditions in oncology. For example, if there is a spinal cord lesion, in the spine, if there is any lesion, or if he's having some lesion in the brain, those are little emergency condition. We start treatment the same day. For that also there is a provision under this government scheme that we can apply an emergency code in certain special situations. Otherwise it is a planned treatment, but an urgent treatment, not an emergency treatment, not a routine treatment. So routine is like you can plan surgery after 4 months, 3 months, whenever you have holidays. So certain surgeries are like that. These cosmetic surgeries you can plan like that. But cancer is not that. It is an urgent treatment. So these are the rules in the government. So again, one point is check that do you have all the reports with you? Because when we are applying for that form, you need to have all the reports. Again, if
Of
there
the
is
CT scan.
CT scan, biopsy. Again, some patients don't get the report. They keep it at home and do it. So here what we have done is sometimes online, if you have soft
Digitized.
copy also will be, because basically we have to upload it. So if you get a soft copy, we combine PDF and upload it. But majority of the patients who probably wouldn't have a smartphone, again difficult for them to send it. That is why we advise them that whenever you are coming, you get all the reports initially, because it's a one-time process. Once we upload everything, within 2 or 3 days we get the approval and we give back all the reports to the patient. So that is one more thing, that when you are having, you check the technicalities of the scheme. Second is, whenever you are coming for this, get all the reports. And once treatment is done, throughout the treatment, whatever the treatment has been documented, if surgery is done, if chemotherapy is given, if radiotherapy is given, that documents have to be uploaded in the end. Once the treatment is over, you submit it for claims, what we call in Ayush, this one. Once the documents are verified, then the government will approve the claims amount or whatever is incurred. So what amount, whether it is enough, not enough, probably is a topic of debate, because generally if you see, the costs are relatively lesser in Ayushman, but that is not this one. It is before the hospital does an MOU with the government, they see that what are the costs and everything. It is a fixed cost. It is available online. It is there in the SAST website. So that is a cost. So
but it can avail up to 5 lakhs. No, 5 lakhs
up
is
to
the
5
limit.
lakhs in a year. That is the scheme. So for example, if
in a year per patient.
per patient, that is there. So if a patient say admitted of cancer, he avails say 75,000. Again, he comes back after some time, then he can avail that. But again, the problem is the overall costs are, the scheme costs are less. That is again a topic of debate. Some would tell that, we have to increase the
Scheme cost, okay. Scheme cost 5 lakhs, not the hospital charges.
No,
usual,
not that. So that's what, hospital cannot charge the patient if it is under this particular scheme, Ayushman scheme.
That is between government and the hospital.
That is between the government and the hospital. They cannot charge. And the government will pay the hospital only that much. That is why majority of the hospital don't take up this scheme as routinely, because they are under loss, because their scheme surgeries are in 10,000, 20,000 rupees range, which probably, OT charges won't add up.
So as a patient, you have to find which hospital would take such a scheme thing.
That's what. Because some hospitals, they enroll for one particular subset. Some hospital may have all facilities under that Ayushman. So that patient has to discuss and take a call in that. But that's what, when I said the cost can be discussed upon. It is a point of debate. Some hospitals will ask government to revise it, government won't revise it. All that things are there. But having said that, because of Ayushman scheme, a lot of patients who otherwise probably wouldn't have had the finances to support have got treatment. That we will agree, that because of this scheme, lot of patients have at least got treated. Otherwise, even though it is 75,000 to 80,000 for say someone who is earning on a daily wage or who's earning only on this one, so it would have been very difficult. So that point is true. We completely agree. Other government schemes are again run by central government, what is called such as ESI, Employee State Insurance, that is there. Something called Central Government Health Scheme, CGHS. These are falls under a similar umbrella.
Can you add Ayushman and these schemes together?
At the
and
same
package
time,
and,
generally they don't. We cannot do that. So that is a rule. That is a rule across any insurance. You cannot club two insurance at the same time together. For example, if he has taken under Ayushman, in future he can take for different thing under ESI. That can be done. But at the same time, it is actually not legal also, I think, because it is not correct. You are claiming from two places.
Right.
So central government schemes are there. For example, we have here NMPT. All those comes under central government scheme. That is the general government things that we see. Then other cooperative insurances are there. In Karnataka, farmers have something called Yashaswini scheme. Dharmasthala runs Dharmasthala Suraksha scheme. So these schemes are not blanket. Only those who are eligible, they can be enrolled in this. So main thing for government scheme in Karnataka is you should have a running ration card. That is the a point at which they differentiate which bracket you will fall. So if you don't have that, only there is no thing. So generally, if patients come to us with that problem, we generally they can check it at any hospital or any government center whether everything is linked or not. Ayushman card, your Aadhaar and your ration card, there is a process to it. Everything should be linked. If it is not there, they should go back and link it as soon as possible. Generally, doctors don't involve too much in this because we get to see these problems. I am telling it because generally doctors we don't really go into depth of insurance and everything. But since I am little interested and I have done work and we get a lot of patients with these problems, I am telling it.
Why you got into economics of cancer?
No, same thing because what I know. Yeah, my aim is that no patients ideally because of financial reason patient not taking treatment is not acceptable, especially in a city like Mangalore where we have multiple options, multiple things. So, and mainly what Lacunae saw is this navigation pathway is not very clear. Now, patients know that there is somebody excess cancer. They know that treatment is there. But how to, go properly, which way to go it? Can they apply, these government schemes? Or they have a private insurance. At their workplace, they have a private insurance. Is that possible? So, all these nuances that we generally face. So, if patients are more aware of these, I'm not telling only about government. No, private schemes also are there. Private schemes, most of the private insurances, they cover cancer. Most of the private insurances, they cover chemotherapy and daycare. That means generally for any insurances, you have to get admitted. Once you admit, then you have to apply for, again, same thing, pre-authorization. They give then you start the treatment. For cancer chemotherapy, because your injection is only 2-3 hours, chemotherapy injections. So why should the patient get admitted for long time? So sometimes they give admission also. They give on daycare basis also. Daycare means patient comes in the morning, goes back in the evening. So there are a lot of private insurances also that is covered. Most of the people working in their, if you're working for a company or if you're working at MNCs, generally they have these insurances. Apart from that also, most of them are taking insurances. But I think I was just, I'm not sure about the data or source. I read it some time back that overall in country, hardly very few percentage have insurance covered. Yeah, I'm not talking about government this thing. Because government, if you have a particular card, you are eligible for it. But private insurance, you have to take the premium and all that. So I think it is less than 3 or 4%. I'm not very sure, but that is a thing. So that also is an option. Cancer treatment are covered in private insurances also, so that it is less burdensome for the family. Even again, when you're taking private insurances, I request that you have to go through what is covered, what not is covered. If cancer is not covered, then there is no way that hospital can help it. Because many of them think that hospital, has not approved it. So hospital is just like a mediator. You have admitted in this hospital, they will they will give the treatment. They will submit all the documents. Approval is given again by the insurance company.
If you were to recommend the best insurance policies, I mean, you are not supposed to do it, you said, I didn't know, like there are insurances which doesn't cover cancer. There may be some people who think this is a affordable premium, so
Correct.
they would buy it, and if anything like related to cancer
it.
would happen, then it's useless,
Correct.
right? So
So
which insurance would cover cancer, like
yeah, no, what generally, no, it is very easy. So generally when you are buying any insurances, in that there will be a checklist, or you can talk to them that basically you have to tell them what you need. So there is something called waiting time. That is one more part of the insurance. That is, if you have a pre-existing illness, that means if you have diabetes. So if you want to take anything for a diabetes care, you have to wait for this much period. So if you say if the waiting period is 3 years, you have to wait for another 3 years for treating anything related to diabetes under that insurance. So that you need to talk to them. So if the waiting period is less, your premium will go up. If the waiting period is more, probably the premium is less.
right.
Inclusions and exclusions, like I told you, you have to check what are the exclusions. Some insurance, like I said, may not cover cancer. There is no particular, because there are thousands of companies.
Right.
So to pinpoint it is very difficult. It's basically it is like a lifetime investment.
Got it.
So it is better you spend some time in that. And third is the co-payment. Co-payment means there are some insurances which is 100% borne by the insurance company. Co-payment means some part insurance. Suppose 50% co-payment means 50% will be paid by the company, 50% you have to pay. That also you have to check. So if it is 100% co-payment, the premium may increase. So all this permutation combination you have to work out and then probably do it. So it is again difficult because we generally don't get into these insurance things, but this is for the public knowledge and it is nothing like secret. It is everything there in the open.
So medical
domain.
insurance companies in India, are they genuinely helpful for cancer patients, or are they designed to make it difficult to claim? You have seen hundreds of cases. Do you see any friction?
It is not friction. It is majority of the time miscommunication or some thing. Generally, what we see is 80-90% of the times there is no issues. 10% of the times what happens is either whatever document we have submitted, probably that is not enough, or there is some error in the document, or we might have forgotten to attach some document. In those cases, what happens is they send us back a query telling that, dear sir, we have noted this one, but we have found out that this is the issue. Can you please elaborate on this? Then we write a letter, and in that 90% of the times it passes.
So government facility, everybody gets it. There is no...
Yes, there is no thing. But only thing, you should have an Ayushman card. You should have the documents. You should have a valid ration card that is in Karnataka. Now, in the coming years, it is already in place. There is a scheme called PMJ. That is all India. The card will be valid. Now, for example, if I want to get treated in Kerala, this ration card or Ayushman card will not, as of now, work there unless that hospital is empaneled. Similarly, for Kerala patients, some hospitals it may work and not. In future, that is a plan, I believe, that in another few years, throughout India, whichever hospital you want to avail these government facilities, you can be in a position to avail. That is up.
So which state government would bear that cost?
No, it is again wherever that state is applied, wherever the treatment is given, that state will, and they have an understanding. Sometimes I think it is 60-40. 60-40% the cost borne by state as well as the government. Somewhere it is 50-50. So that is again depending on the MOU between state and the government. But over large, health is generally a state subject. That is, state leads the initiatives. That's why if you see most of the district hospitals, everything is under state. Unless it is a central government institution.
Right.
Otherwise, state
How are we doing on health matters?
Yeah, we are doing okay, I believe, because but a lot of scope is there, needs to be done.
Which areas?
Yeah, so generally when we mainly I feel in the accessibility areas. Now for a city like Mangalore, I told you, we have enough and over medical colleges, enough and over hospitals. So for Mangalore it is okay. But if you see Karnataka as a whole, I believe and it is evident that the majority of these hospital healthcare is not divided properly. Now you have all districts of Karnataka. Majority of the healthcare is in Mangalore, then Mysore, Hubli, Shimoga, in and around these areas. If you see a bit of North Karnataka and other areas, so the accessibility is a problem. So there is a place, for example, Mangalore, where we have a population of 6 lakhs, 6 to 7 lakhs. We have 8 to 9 medical colleges, around 20 hospitals. Similarly, if you take a remote area in Karnataka, where they have to travel 300, 400 kilometers. So probably equitable distribution of healthcare facility is important, because healthcare is one of the basic necessity. So we have patients who have been coming from 300, 400 kilometers, the overnight bus and everything. So can we really distribute the wealth more equally, the healthcare facility more equally? That is one concern. Second is urban-rural divide. So that is a long-standing debate. So majority of the centers are focused in urban areas, be it cancer treatment center or the hospitals. So most of the treatment centers are focused in and around urban, not around rural areas. Before it was more in tier 1 and tier 2, but at least now we are having few hospitals in tier 2 and tier 3. But majority of the work is not really distributed well. That is one point where we need to improve. So in Western countries like UK, there is something called an NHS scheme. That is the government sponsored scheme, where there are fixed pathways. So both pros and cons are there. Pros are that you have a fixed pathway wherein you'll be seen first by a general physician, then they will refer to a specialist, then you see. The cons are that the waiting time is slightly more. For example, in India, if you want to get a CT MRI, I can prescribe you if there is a need. I can prescribe you now. In another 1 hour, 2 hours, you can get done with the report.
Yeah.
So that is not possible there. But India has its own set of good things also, a set of where there is more scope for improvement also. Good thing is that the same quality of care, the same equipments that are there, if we compared to the Western countries, we are able to offer it at a very, very much lower price. I think recently there was a news, a Google CEO, I think got his surgery done for his mom, and he had taken, I think, 2 or 3 estimates. One was from Singapore, I think. One was from India. So it's significantly less when compared to India. So India is a major, I believe, next 5 to 10 years. Somehow, if we are able to capitalize on this medical tourism.
Right. I think Mangalore has a huge potential.
Mangalore has immense potential.
Mangalore has immense potential.
Yeah, 2-3 hiccups, I believe, is the connectivity. Because when you talk about, say, international patients or medical tourism, our airports, air connectivity should be sort of strong. We have good, no doubt in that. We have a good facility as of now, but it can be improved. So that
connectivity to which are the regions to become like flight connectivity to which of the global regions for Mangalore to become a next healthcare destination.
Yeah, so I think, see, for when do patients come for medical tourism is, whenever that much facility is not already there, or they want an alternative facility. So I feel Middle East, we have good connectivity as of now. Middle East is a very good, place where because we have a lot of our Indian diaspora there, who also come here for treatment. If you see, we have a lot of patients who are coming back. Even, Southeast Asian countries like Singapore, Malaysia, Thailand, we can capture that areas also, because we have very good infrastructure at par with all these countries. Another is African countries. African countries, I think one issue, I have not gone in detail or read in detail, but probably the infra is not that up to the mark what is needed. So definitely there is an opportunity.
Right.
So these 3 regions, and also Central Asian countries. From these 4 to 5 regions, it can capture a good potential. Because Mangalore, if you see, healthcare has been one of the strong backbones of Mangalore. One is definitely economics. For example, banks. A lot of banks have originated from Mangalore. Similarly, a lot of doctors have studied from Mangalore in these medical colleges and now go on to become big doctors. Most of them are also in Mangalore.
Right.
So Mangalore never had that problem of no healthcare. So before, for any treatment, for example, radiotherapy only, what has evolved from many years. Before, patients used to go to Bangalore, Bombay for higher end treatments. But from the past 5-6 years, no one is. We only have all the facilities in Mangalore. So no one is going to Bangalore or Mangalore. So Mangalore has that potential to definitely become one of the, because it is already a healthcare hub.
Right.
You have,
And it's also prices are also
prices are
in
very
par
competitive.
with the.
Yeah, it is very,
It's
very.
not hypercharged because there are 6-7 hospitals competing.
Correct.
The economics make sure the prices are fair as well. No?
Correct. Because it is, if you see, it is a healthy competition. Even if you organize any program, you will see multiple hospitals coming together and doing it. For example, any health initiative, you will see KMC, NITTE, NAPAI, all combining hands and doing it. That's why it is a healthy competition in Mangalore, if you see. And that is a good thing, that, patient has options, patient can, definitely has the thing. And more importantly, overall ecosystem of healthcare and medical education is good in Mangalore. For example, KMC started in 1952. Almost we are celebrating now 70 years of medical.
Right.
So with 70 years, every year there have been 250 students of MBBS passing. So that many doctors have come up. And also there is something called a public-private partnership with the Venlock. That was the first in the country, where KMC is the public private entity, but government Venlock Hospital is the public entity. So they are having collaboration. So patients, doctors, human resources, facilities are provided by KMC. Infrastructure and other government infra decisions are taken by the government. Now, if in cancer care only, we are running OPDs in Venlock. So that is run again by the KMC. We are giving now chemotherapies in Venlock from the past 2-3 months. Nice. Under a scheme called hub and spoke model. So the doctors, everything is from the KMC. That is a good model. But
hub and spoke model.
Hub and spoke model. Public-private partnership. So it's called PPP model, public-private partnership, wherein both people are benefited by the initiative. So similarly, in healthcare in Mangalore, I don't think it is it is there. Definitely, lacunae are there. But if you want to avail a facility, I don't think, because lack of facility shouldn't be the reason for not taking treatment.
Right.
Yeah. And third, coming to the point of, we've discussed about government schemes, private. Third, there is a lot of NGOs also that work with us for cancer care. For example, last year itself, we had 2 to 3 NGOs support us for almost treatment for almost 150 to 200 patients. So they support both. Some support financially. Some of them, they give, say, nutritional supplements. Some of them, there's an NGO who has given, wigs for patients. So some support, everyone does. So even for childhood cancer day, there is a lot of support coming in. So community involvement and NGOs involvement is also there. What I personally feel is that, any cancer patient, because of no finances or no money, not receiving treatment is not right in this particular era. Because we have different avenues. Even if they don't have their ration card, or they don't have Ayushman card, some issue is there, can always ask some NGOs to help us out. So definitely good work. Whenever it's good work, definitely they will.
Any shout out in NGOs?
We have the Indian Cancer Society. They work with us a lot. Then we have Akshaya Foundation. They work with us a lot. Moolatva Foundation, we do have support. They have
so
supported
is it
us.
NGO hospital partnership or something?
No. In India, if there are some finances involved, then definitely they have to do a partnership. For example, if they want to, say, give some financial support to a patient, they directly will not, probably give the patient because of the legal and other issues. So they give it through the hospital. In those cases, we do. So that is one part.
And how quick is it to claim from the NGO? Like,
It is 1 or 2 days.
oh,
Generally,
that's it.
Yeah, that's it. So generally, what we do is we tell the NGO that treatment is there. So they give us a heads up that you can go ahead with the treatment. Then whenever they reimburse the hospital, that is, I think, 10 to 15 days is what I think.
Nice work.
Yeah, but that is good work by them. And there are a lot of NGOs who don't support financially, but they help us in community awareness. That is, they help us organize camps,
Screening camps.
screening camps. They help us organize these talks. What they do is they do a groundwork there. They talk that a doctor will be coming from this particular hospital. They'll be coming from the oncology center.
Right.
Then they will gather a few 100, 200 people, then give a talk, ask their suggestions. So those were types also. A lot of NGOs are working.
So do you see any ideas for NGO formation which nobody has addressed before in the cancer care? Just a brainstorming question.
I think this only finances.
Finances,
only.
okay.
At least giving awareness on finances, awareness on navigation, that what the patient is supposed to do in case you have been diagnosed. That is not there. Now the NGOs definitely they will fund for a screening camp. That is anyway we know that it is there, and they will fund for finances. Some of the NGOs, if they want to support the patient, they will do. But in between, from the patient's home till they reach their treatment center,
Travel, food,
stay, all that can they do. That is a thing.
Invisible
And
cost.
one more important thing that probably some NGOs can do. I'm not sure. Some NGOs may be doing it. Post treatment, can we sort of rehabilitate the patient with some sort of job or some sort of earnings for the family? Like generally they would have taken a break from their work. Who have fixed work, it is okay. Generally they get leaves and everything. But in the unorganized sector, a lot of them find it difficult to go back to that same work. So can they facilitate something so that the patient's livelihood can be restored? So we have had a few patients who post treatment also went back to the same work. But sometimes it is not possible. Sometimes that work would have been given to somebody else. So whether patient treatment along with that rehabilitation of the patient or restoring the livelihood of the patient or the patient attender, is it possible? It is difficult, no doubt it is difficult, because you need that amount of dedication, but I see lacunae there that probably we can work on.
There are Indians who going to Thailand and Singapore for treatment.
Yes.
Do you think it's worth it when we have good healthcare here?
Yeah, we already have pretty good healthcare here. Certain few things which are not available here, that is very, very higher end techniques. Probably patients might go for that. For example, when we talk about probably 5-10 years back, robotic surgeries were not available in most of the places. Now it is available most of the places. In radiation therapy itself, what we call the stereotactic radiotherapy, wherein if any small lesions are there, we can treat it in a single day. That is very high end technique. Before it was not available. They used to go to other countries. Now it is available here only. So which are not available, definitely going there makes sense. Otherwise, I feel we are good. We have a good future.
India is catching up in
healthcare. We have to trust our system. But again, that it is a definitely thing that some probably very high-end techniques which are available in few areas of the world. Probably they may go for that.
Do you see patient paying out of the pocket for cancer treatment?
Oh, yes.
How often is that?
Yes, because...
And why do they pay, like when there's insurance, the government policies and those things?
So when we talk about all these insurances, they pay only for the cancer treatment. That is, I told you, it can be either surgery, it can be radiotherapy, it can be chemotherapy. Now, apart from this, what we call as out-of-pocket expenditures. So patient may be coming,
the invisible cost.
Invisible cost.
I was asking Are they paying the radiotherapy, all this cost, surgery cost, from the out of their own pocket?
That's what. If they don't have these insurances, then generally they have
Do you
to.
see it often here?
Yeah, we see some paying patients who are,
Okay.
we do see. And some of them want to, take it under cash also.
Like if you look at the spectrum of cancer treatment,
Yes.
like we have so many variations, like stage, type, treatment modality, duration,
Yes.
so many things. So
Yes.
what could be the cost difference in treating a cancer?
Yeah, stage 1, if only a surgery is required, then the cost could be as less as say 30 to 40,000 for a simple surgery, say of a breast or anything. Where a small surgery is needed. Whereas if it is a stage 3, stage 4, where multiple modalities like immunotherapy, SRS, everything, it can go up to lakhs. That is probably I think more than 15 to 20 lakhs it can go. So that is a wide spectrum.
That's why you need to have insurance.
And so you need to have a better financial planning.
Do Ayushman apply to that range, 20 lakh, 15 lakh?
Ayushman has a fixed code that we
5
do
lakhs.
not fit. Not 5 lakhs. 5 lakhs is the amount. But within that 5 lakhs, there are these codes. For example, if you want to do this particular surgery, that particular code should be there under Ayushman. That is again fixed by the government. We don't fix it, neither the hospital fix it. For example, certain immunotherapies, it is not covered under Ayushman, so it will not be covered. A few newer medications, because these costs have been done few years back, it won't be.
It's not
covered.
updated.
Not updated, so it is not covered.
So what do people do, when costs are so high, they give up the treatment?
If the cost, some patients, if the costs are very high, that is why we see certain them from the treatment, that they will not come back because it is not affordable for them.
And is there cases where costs are so much and probability of survival is not 50%? So
Correct.
the decision of whether to do or undergo that,
Yes,
and the weight of decision,
correct.
it's a lot, right? So
Correct, I
how do
understand.
you navigate a patient with that? With that situation.
Correct. So we clearly tell them that this is going to be the outcome of, say, using this particular newer drug or newer treatment, which is going to cost you so high. What is the final outcome in that? So if the patient, if there is a outcome, very dismal outcome for few months or few days, is it worth really spending so much? So then we discuss with the patient. Some of them, they agree that yes sir, it is correct that we know that it is completely not going to cure. It is only extending few time. So then this cost is very high that we cannot do it. So we won't want to do it. But some of them would want to do it. That it is okay, sir, as long as it is there. Let us try it. What is the best treatment possible? What is available? Let us do it. Cost we will try to take it. So it is completely a patient's decision. We don't.
Right.
So we give them the options. Finally, it is them, but it is our duty to convey it so properly.
Right.
Now, I should not tell that this treatment will have very, very good survival, because we speak on the data, we speak on our experiences and the patient. So it is up to the patient to finally take a call of what is needed.
Cancer treatment is, cancer economics is basically about timing,
Yes.
transparency, and choices.
Yes, choice. Yeah, that you said it rightly. I also never thought. That is a good
Summarizing
wording.
it.
Yeah, summarizing. Yes.
So now I see the point. Why screening is absolutely necessary.
Yeah.
Otherwise, somebody else would pay the late stage treatment, right? If you screen them earlier,
Definitely.
less money we have to pay. Even the screening costs some penny. Money.
Yeah, a few money. That is saving in the future.
Right.
Definitely. That is the whole point of screening.
Public health care. It's a
healthcare,
huge topic.
It is a huge topic.
On economics, I'm talking about economics.
We have just talked about within that public health, cancer
If
in that.
our nation is healthy, I think we can spend that healthcare money on other things.
Yes, other things and do it. That is true. That is true. Because overall, that is the message is that people, let them be more aware of what is it. It is up to them. Choices is up to them. Right. We never tell that you have to go to this particular hospital, this particular doctor. But at least they should be aware of what is happening.
What is the most advanced thing in cancer treatment, most advanced?
See, most advanced at present, I would say in surgery, it is more of
Robotic
surgeries and guided surgeries. So before surgery was done directly open, now you have robotics.
Why robotic makes sense? Does it decrease the cost or increase the precision?
No, one is increases precision. Second is it is very, very accurate. So basically, robot means robotic surgery. Robot, there is no robot doing the surgery.
I know.
It is the humans only doing.
Right.
But the precision is very, when you sit on the console, say if I want to cut 2 mm, 2 millimeters, it will cut exactly 2 millimeters. And the recovery time is also much faster because very minimal disruption occurs. When you open, there are few blood vessels, few nerves, it may get cut. That all risks are not there. Recovery time is much faster and minimal incisions. If you see a robotic patient who undergone robotic surgery, very 2 or 3 this will be there. So that is upcoming in surgery.
Cancer
that is now,
right.
we don't know in future. Still
Do we have robotic surgery?
in Mangalore, it is going.
Mangalore?
Yeah, it is going.
Nice.
Most places have it. Not anyway, it is there.
And which costs more? Like
cost
laparoscopic, robotic
is slightly costlier, but I don't think it is significantly long, but it is definitely costlier. And the second is coming to radiation therapy. Before radiation therapy was given on older machines called cobalt machines, but now we use linear accelerators, that is Linacs, what we call. In that also certain techniques are there. That is
like why radiation therapy is nice, like targeted radiation, is
yes, it is basically X-rays, but high energy X-rays. So it targets the cancer cell and it kills the DNA of the cancer cell.
Targeted cells.
Targeted cancer cells, and cancer cells die because of that. That is how radiation works in simple terms.
What if a cancer cell is below some other cells?
Correct. So that is why whenever we give radiation, some amount of normal cells also gets affected. But in normal cells, it has a potential to regrow. In cancer cells, it is not like that. Once it dies, the normal cells, if given adequate nutrition and other things, it will regrow. So that is why the change in techniques. So as advanced techniques are there, the dose going to the surrounding normal structures is less and less. So we have a technique called stereotactic technique, that is we are doing routinely. So in that, if the cancer size is say very small, less than 2 to 3 centimeters, we give only to the cancer cells. Surrounding cells do not get even significant dose because of the very, very high precision.
So if I have a cancer in my GI,
Yes.
so how, like, you just expose me to radiation, or do you have to cut open some parts?
No. You don't have to cut open. So what we do is wherever the cancer is there, we have to treat that area with an X-ray or X-ray based treatment. So you would have seen the CT scans going in. It is similar machine called a linear accelerator. So what we do is there are 4 steps basically in radiotherapy. First is called molding. That is we make the patient lie down on the machine, and we have to make sure that during treatment patient does not move because it is very precise. So if you move, you may miss the tumor.
Even an inch? Oh.
Yeah, we are not supposed. The patient is
You
supposed.
tie the patient.
No,
is
not
it?
tie. So it is called a molding. We have a sort of a mask that is made of thermoplastic.
Oh, it is customized for the patient.
Customized for the patient. Only during the treatment we place it. But it is comfortable. It is not tight or anything. It will be comfortably tight so that the patient doesn't move.
Okay, that is one.
Yeah,
No, then
that is the first step. Second step, with that mask and everything on, we take a CT scan of the patient. That is step 2. Now, step 3 is on the CT scan, we mark each and every slice where the tumor is there. So there will be around 1,000 slices, sometimes 500 slices, sometimes 100 slices, sometimes 1,000 slices, depending on what area, how big the tumor is. So each and every slice is marked on a CT scan. Now you would have seen many
slices
CT,
X and Y axis of
all
the
the axis,
organ.
everything.
Okay.
So that when we draw that particular tumor, at the end, entire tumor will be covered. So along with that, we give some margins. Now we know that tumor is there. Surrounding also, we give some margins. That is the third step. The fourth step is radiotherapy planning. So now we know that there is a tumor in the ear, but we also know that our normal organ, liver, comes there. Behind our colon comes. There may be lungs there. So we have to avoid that region. That our team, they are called medical physicists. They plan it that this particular dose radiation should go only to this point, should not go to any other structures. So that takes 1 or 2 days. So that is the fourth point. Fifth is delivery. So once everything is done, we treat the patient on the machine. So on that day, that radiation, wherever that is there, it is delivered. So generally, radiotherapy is not given in 1 or 2 days. It is generally given in split, generally 20 days, 25 days sessions.
Why so?
Because the dose to be delivered is very, very high. So if you deliver single day that much dose, it may harm the patient.
Kill that tumor cell
in one day. Yeah.
Okay.
And when you give over many days, it is shown that tumor cell, they respond or they get killed more efficiently instead of one single dose.
Right. So in that case, like if you expose a patient to radiation, X-rays
Yes.
multiple times,
Yes.
and if you make them pass through over other things. I mean, even X-rays are high energy radiation, right?
Correct.
So what did it cause? A risk of another type of cancer?
Secondary cancer. I
right,
understood.
right.
Yeah. In 1970s and 80s, this was a major concern because that time we didn't have the sophisticated equipments. So if you have to treat the small area, we have to treat an entire area because we didn't have things to shape according to the tumor. So whenever we are treating, say, a small tumor, our radiation machine will adapt to that size. So that entire area need not be treated. So in those time, it was a major issue. Now what has happened is only that tumor, wherever the tumor is there, only that much area we are treating. And this is generally being treated in a patient who already has cancer. So secondary cancer risks, it is definitely there. I'm not telling it is not there. But hardly we see. We don't see any, I think in the last 20 years, we have not seen even one. Because it is mainly dose dependent also. So whenever you're treating tumor, some amount of dose will go to the surrounding areas, but they are sort of able to repair themselves. So secondary cancer risk in the present era, we don't see that much. So why this 25 to 30 days is, if you're giving in a single day, our surrounding tissues are also not able to handle that much dose in a single day. So this was a case another 10 years back. But now, for certain cancers, we have an advanced technique called stereotactic techniques. In that, treatment is finished in one single day, provided that the tumor size is not very big. That is the pitfall of it. That very huge tumor size, 15-20 centimeters, we cannot treat with that technique.
Radiotherapy.
Radiosurgery it is called. It is like knifeless surgery. Single day treatment is done.
Radiosurgery.
Radiosurgery.
Stereotactic
Radiosurgery. Stereotactic means the axis, X, Y, Z.
It rotates the patient, is it?
A patient will be stem. The machine will rotate.
Wow.
Yeah.
Crazy innovations.
Even patient, we cannot rotate the patient full, but we have something called a 6D couch. That is in 6 directions, front, back, and this direction the couch will move. It is called pitch, roll and yaw. So up to certain degrees we can tilt the patient. Up to 3 degrees. Slightly if you want some angulation. If you want the dose, that can be done.
Do they feel anything?
No. It is painless. No?
Without anesthesia, right?
No, it is not without anesthesia. We don't admit the patient also. We admit the patient only if they are from far off.
Wow.
Otherwise, they are coming from home.
It's like get the cancer diagnosis, fix the day to radiosurgery.
Yes.
And finish the radiosurgery, go back home.
Yes.
Done
Only
with the
thing is,
cancer treatment.
radiosurgery, tumors less than up to 5 centimeters, we can comfortably treat.
And how often are those such cases?
I think 30%, 20 to 30% easily.
Not bad.
If there is a larger size, instead of treating in one day, we can treat in 3 to 5 days.
This is for stage 1, no? Makes sense.
Majority of stage 1. And sometimes what happens is patient... So when do we tell it's a stage 4? It has spread to other areas. So sometimes there is a situation where, the cancer is there, for example, in the breast. But it has spread to only one small area somewhere else. For example, in the liver or in the bone. That time also we can use these techniques. Because then you have just one single lesion anywhere else. Entire body it has not spread. Those time also we can use this technique. But it's an advanced technique. Before we used to not have here, but nowadays we have in Mangalore. Over that we have something called a proton therapy. That is in India, only 2 places, Chennai and Mumbai has it. Actress Mumbai has it.
Interesting.
That is again a different type of delivery, but
You deliver high energy protons.
protons. Yes, protons
Protons
are
of?
used. Protons of helium,
Wow.
hydrogen.
Wow. Okay.
Yeah.
So targeted to the
Tissue cells.
Just
So
like
in that
X-ray.
even further we can, just like an X-ray, but the machine is huge. It is almost, I think, double the size of this area.
Wow.
Investment is very huge. It is in
Okay. What is the advantage of that?
proton is same that it is further reducing the dose to the surrounding areas. Then there is something called carbon ion therapy that is not there in India. Only few Western countries.
Whoa, this is very
Yeah, it is a
sophisticated
huge,
sci-fi movie kind of.
Very basic machine also you can treat cancer. It is not like that. Only thing is how efficiently you can treat and how minimal side effects you can give to the patient. And the second one more advanced technique is what we call as respiratory gating. So now few tumors they move with respiration, especially lung,
Okay.
liver. When you breathe, the tumor also will breathe. Tumor also will move up and down, sideways, sometimes front and back. So now how do you counter that? So if a tumor is moving and you are just treating one tumor in that small area, we may miss the tumor. So there is one more technique called 4D respiratory gating, in which
Wow.
the machine will, sort of
Understand the rhythm of
of breathing and treat it. So that all these are very, very advanced techniques which were not available before.
Now we have those things.
We are routinely using it. So that is a good part. So much development has.
How much those machines would cost?
It is in crores, I think.
Like how many
Linac may cost somewhere 30-40 crores.
Wow.
Proton will cost 700-800 crores.
And 2 hospitals in India.
One is Apollo Proton, second is Actress Mumbai, Tata Memorial. Right?
Oh, again, it's in the not in the consumer space. Again, in the research space.
Yeah.
It's a philanthropic thing, I guess.
I think so. But they are treating patients in that also. Apollo Proton is also there.
I mean, if the cost difference like from 70 to 700 is 10x. So
It is 10x.
even the cost of treating
It will
cancer
be,
should be also 10x, not to make it.
It will be.
Right.
So that is about radiotherapy. Coming to chemotherapy before 30-40 years.
What is hormones and what is chemotherapy?
Chemotherapy is basically a drug, chemotherapy drug. It can be either injected, given intravenous, injected, or there are chemotherapy tablets also available. Within chemotherapy, now we have different domains.
Their function is go to that cancer cell and
Cells
kill
and
them.
kill it.
Just
So-
the cancer cell, nothing else.
So what happens is that is the main aim. In ideal situation, that is the aim. That wherever cancer cells are there, these will go and bind to those cancer cells and kill it. But sometimes normal cell also gets affected. That is why in some patients, if you see of breast cancer, it will attack the breast cancer cells also. But at the same time, our hair follicles also gets attacked. That is why they have hair fall. Some of them they have diarrhea, loose motion, because some amount of
Right.
normal intestine cells also gets affected.
But how those drugs are designed such a way that it attacks the only cancer cells?
Because they have something called a binding or a receptor. Only if few cancer cells express those receptors or express those things, then only the drug will bind. Normal tissue, majority won't express that. It can be vice versa also.
Okay.
That normal tissue has this, cancer tissue doesn't have this, so it will attack those cells. That can be there.
So since there are many variations in
Yes.
cancer cells, there are many variations in drugs
Yes,
also.
drugs also, type of cancer cells. So drugs, the newer ones are called as, immunotherapy drugs, wherein you are using the, body's immune system itself to kill the cancer cells. CAR T cell therapy, you would have
Yeah. Can you tell me more about that?
Yeah, CAR T cell therapy is similar. It is
It's a
works
cutting
on,
edge of cancer treatment,
it
right?
is
CAR T therapy.
CAR T cell
And
therapy.
even somebody won Nobel Prize on CAR T therapy
CAR T
recently.
therapy. Yeah, that is the current, like it is upcoming in
So
many ways.
you train your body's immune system to itself to attack the
So basically, you take the our body's immune cells out. You prepare that whatever immune cells are there in the body, and then re-inject it back so that it goes and attacks the cancer. In simple words, there are multiple,
Right.
Also immunotherapy, again, there are different types. Certain it will block the immune cell, the cancer cells from multiplying by blocking certain signals. Now cancer cells will give signals to the body, and that's why sometimes the cells grow. These immunotherapy cells medicines go and block those signals, so that can happen. Chemotherapy, in a broader term, it will go and attack directly the cancer cells, but it has its own side effects. Like I told you, they can have, most commonly they can have this nausea, vomiting, hair loss, that can be there. Immunotherapy, not that much, because it is even more targeted.
India has immunotherapy?
Yeah, immunotherapy is routinely used. It is,
wow, okay.
it is
I thought it's
used.
cutting edge.
No, it is routine. It is just so chemotherapy is given as an infusion. So it is just like how you put when patients they have weakness, or you would have seen patient getting a glucose infusion or something. Similar to that, we add the medicine into that. That's all. Chemotherapy is given. Most of the chemotherapies are given on a 1 hour to 3 hour infusion. Immunotherapy is even less than 1 hour to 2 hours maximum. And we also have chemotherapy under the bracket. We have something called targeted therapies. That time I discussed about HER2 breast cancer. So only that particular targeted,
it goes to the cellular level, right?
And targets them. That is also there. All these are broad forms of chemotherapy. That is the main. And tablet chemotherapy is also there. Generally in brain tumors, we use tablets, because normal chemotherapy does not cross that well into the brain.
Brain blood barrier.
Yes, brain blood brain barrier.
Blood brain barrier.
So our chemotherapy, all medications will not cross except a few. So in those medications, they are available in tablets form. So whenever patient is getting treated, along with radiotherapy, sometimes we give tablets also. So like that, many advancements keeps happening, and it is there. Only thing, see, this immunotherapy, why is it costly? Is because these have been developed by after years of research, after that much investment. So until they have a certain patent period.
Right. It has
so
to be.
Once that patent is expired, then multiple other companies can do it.
Right.
Now to give an example, there is a blood cancer called CML, chronic myeloid leukemia. When that initial drug, it is called imatinib, it came, the per month cost was in lakhs. This was, I think, 2000s, around that time. But now the cost is 800 to 900 rupees a month.
Wow.
That cost, yeah.
From 2 lakhs to 800.
2 to 3, more than that, I think, the original molecule.
That's the beauty of economics, no?
Correct.
The human progress, how the cost also comes down. For every
because
technology.
after few years, that patent got expired. So till that patent is there, no other company can produce it. That is illegal. So once that patent, I think for 15 years, that is expired, multiple other companies can use it. And now it is one of the most, highly used drug for that particular condition, and it's got very good results also.
Nice.
So that is the thing. That cost is definitely a factor, because now so much, like you said, so much investment, so much into research would have gone, and all these investments are the molecular level.
Right.
So the costs are quite
going
high.
ahead with the AI also helps in simulation, and you can reduce the cost, drug development price.
Could be definitely. They must be looking at that options too, I believe.
Right.
Yeah.
Okay, these are the treatment modalities.
Yes.
Surgery to robot surgery, radiotherapy, many things, and chemotherapy. Yeah. So for treatment, you decide on the combination.
Yes,
which
depends on
best,
what stage, what type of cancer, and what best is available for the patient. That is what we decide upon.
There's too much brainstorming, no? Like you have to first is cancer profile there, and then what financial situation the patients are in, and then the like combination of these three, like which one
to go, how to go, what is the benefit. All this has to be told to the patient also.
that makes this feel interesting. Every time there is variation,
And
you're not sticking with the
interesting
same
or not,
routine.
I don't know, but it is again difficult because
Emotionally intense,
yes.
logically too much
too much
computation.
and daily something is happening.
And
Research
very
is-
impactful profession.
yeah, it is
You're
true.
helping people save life, and
That is true. That is true. That is true. But that's what. These are some problems we face, that we will explain a patient that this is the treatment, this is how it's going to respond. But it won't happen, may not happen that way
Right.
in all the times.
if even if you have like, where does advanced technology genuinely change outcomes, and where does it not?
Yeah, sometimes these younger patients we prefer advanced treatment. Generally, areas where of many critical structures are there. For example, brain. Generally, we prefer little advanced surgeries, advanced radiotherapy, because our entire control of the body is in the brain. Certain areas where still simple treatment is okay. For example, if you're having a tumor in the forearm, arm, or the leg, which is still okay because major critical organs are not there. That is okay. But mainly for radiotherapy per se depends on the location. If it is non-critical, it's still okay to go ahead with. But if it is critical, then better to go in for a higher end technique. Surgery also is the same. It is there is a lot of difference when you operate a breast tumor versus when you operate a lung or a tumor that is deep seated, because the risks are higher, everything is higher. For breast, simple surgery may be enough, but for lung or this thing you may need guided surgeries. Even for brain, for that matter, you will need.
How do you operate a lung, such a delicate organ?
Our surgeons are
Exceptional.
because even lungs and heart all are moving organs. So you are operating at that
Wow.
time. So I
Can't
think
compare.
technology, definitely there is technology. There is a lot of role. We have this navigation techniques and everything.
Right.
So with that, it is, but definitely it is difficult. You have
Lung cancer.
lung cancer, brain tumors, lung cancers, deep seat abdomen. So it's okay, but deep in the abdomen, pancreas, and all that are very difficult. There is a cancer called, of the adrenal, wherever kidney is there, above kidney. So the problem with that is, you try to touch it, it may release so many this thing into the body that patient can have problems.
Adrenaline gland.
Adrenaline gland, yes.
Okay.
So you cannot, touch it too much or fiddle it too much.
Flight and flight
Yeah,
response. Flight and flight response.
It's called pheochromocytoma is the name of this. But generally, you have to control because sudden release of those, your BP can go haywire, entire thing can go haywire. So very delicate.
Very rare tumors are those.
Yes.
And how do you treat those
Mainly
radiation?
those are mainly surgery. If surgery is not possible, you can treat with radiation also. But that's what. In those cases, our minimal invasive techniques might help. Because if you want to touch, say 1 mm, it will touch only 1 mm. So those things, it will help. So certain situations, definitely robotics and other things will help.
So chemotherapy would come from stage 3, is it?
Not like that. So chemotherapy generally, most of the patients would receive in stage 3 and 4. But certain indications in stage 1 and 2 are also there. For example,
Just to be on the safer side. or
if you
something.
feel that the tumor is aggressive, if you know that it is high chances of coming back, then we give chemotherapy.
This is a good question. What do patients usually misunderstand about modern cancer treatment? What are their most usual questions about the treatment? Like suppose I can guess radiation, like
Yes.
radiation is harmful, they would say. Even I would say something like that. So are there any similar questions patients would ask or misunderstand about the treatment process?
They misunderstand, I think, little bit about the duration. They feel that still, for oncological surgeries, in all surgeries, for example, they have to stay for months together, which is not the case. Even for radiation therapy, the duration is significantly shortened now. They don't have, I told you, they don't have to get admitted also. We don't admit the patient also. Chemotherapy also duration is less. Uh, when we tell duration, it also means how many days they are getting treated. So although cancer treatment, chemotherapy is for 6 months, within that 6 months he is getting treated only for 8 to 10 days. So that is one misunderstanding they have. Second is about the cost, definitely, that we have discussed. They have misunderstanding
Right,
about the
right.
cost, that is surely there.
That's genuine. Yeah.
Yeah, that is genuine. Third is what sometimes what extra benefit are they getting from that queries do come, that will it significantly change the outcome or not. So in certain situation we can tell them no, but
Right,
sometimes it becomes gray area, that we really don't have data or to tell that it is the case.
I will have my last question. What excites you the most about where cancer treatment is heading?
Technology itself, that now overall treatment time, as well as help us guide which cancer treatment will work in which patients. That is called personalized medicine, so that we are upfront, we are prepared for it. Now I know that a patient is going to have a very, very good outcome. Should I really subject him to all modalities of treatment? Vice versa, if I know that patient is going to recur, do I need to be extra careful? Do I need to be this? So if technology can help us do that, that will be great. But again, cancer treatment, it has significantly changed. There is no field in medicine that has so much research and so much things going on. So that excites me the most, that there is a very good future where we can help the patient out. So future, I'm not telling in terms of increasing cancer cases. That is not the thing. What I'm trying to tell is there is a future where we can use multiple modalities. We can use both man and the machine. Man means the involvement of doctors,
Robotics.
involvement of community, involvement of our support staff, involvement of people to improve the cancer care. Second, you can use machines, that is involvement of robotics, be it advanced technology. Next, in future, we don't know what will come up.
Right.
So all those, both combination of both the personals as well as the machine technology, that is going to make a good outcome and give us a good outcome in cancer. Thirdly, per se, for Mangalore, Mangalore should be known as one of the pioneers in cancer treatment, because a lot of institutions are there. We definitely collaborate. We meet up. We collaborate on a research note and every note. But it is very important that Mangalore be identified as a good center for oncology, so that we are able to give good, affordable cancer treatment to any patients, so that no patient, like I said that time, no patient